Hello.
Good evening, sir.
Hello. Good evening. Am I audible?
Yes, sir.
Yes, sir.
Okay. Today, Dr. Kamakshi is not in station. He is in Jodhpur, Rajasthan.
Yes, sir.
So he just called me to say that we can go ahead. He has made all the settings. And, we can start the class if all of you are ready.
Sir.
We will not wait for him. So
Yes, sir.
can you inform your friends to join as quickly
Yes,
as
sir.
possible?
Yes, sir.
You have
Good evening, sir.
Good evening, Dr. Abhirani.
Good evening, sir.
Good evening. Yeah. Who is presenting the first case scenario?
Sir, I am presenting, sir.
Others are finding it difficult to join. Shall we start or shall we wait for a few minutes?
We can start, sir.
Okay.
So, good evening, everyone. Good evening, sir. Today we are going to discuss regarding on preeclampsia. So, the given question is a 24-year-old preemie at 34 weeks of gestation admitted with complaints of severe headache, visual disturbance. Her BP is about 190-118 mm mercury, and she has bilateral pitting pedal edema. She was diagnosed as preeclampsia at 24 weeks of pregnancy and was treated with tablet nifedipine 20 mg BD, which she is taking regularly. Now, how to manage it now? The given patients already diagnosed with preeclampsia, now presenting with complaints of severe preeclampsia, as the patient is having headache, visual disturbance, and the BP is more than 190-118. She's also having bilateral pitting pedal edema. So the first we should admit the patient in the hospital immediately and control her BP, as uncontrolled BP can lead to further complications like eclampsia, pulmonary edema, intracranial hemorrhage, and HELLP syndrome. Then we should put an IV line and start. We should put an IV line and send the blood for investigations. After that, we can control the BP with IV antihypertensives. As her BP is more than 190-118 mm mercury, we can start with the injection labetalol of about 25 mg IV bolus. We can be repeated every 15 minutes, which can go up to a maximum of about 200 mg. If the BP is not controlled with IV like labetalol, we can start with IV hydralazine. Following the controlling of BP, BP monitoring should be present throughout every 50 minutes interval. If the BP is controlled and if the symptoms start subsiding, then we can switch the injection to oral tablets. And seizure prophylaxis should be given with magnesium IV injection, magnesium sulfate, about 4 gram IV, followed by infusion of 1 gram IV till delivery or post LSCS. Then as the patient is about 34 weeks of gestation, if the symptoms subsided, we can continue the pregnancy till 36 weeks and terminate after 36 weeks. But if there is any fetal distress or if there is any threat to maternal and fetal life, then we can immediately terminate the pregnancy via LSCS. Single shot LSCS is preferred in rather than GA, as GA has can aggravate the hypertension by the intubation extubation response, and that will be, it's a high risk procedure due to the difficult airway and due to maternal complications. And for the regional anesthesia, we can if the patient is coming after 36 weeks, if the PP is stabilized and completing after 36 weeks, we can give a labor analgesia by a continuous spinal epidural analgesia, and we can after induction of labor, if the patient is delivering, we can convert to vaginal delivery or continuous as spinal.
Continuing as spinal.
No, sir. Or we can
for surgery.
Yes, sir. Then so we should look into the investigations before giving regional anesthesia. Like we should look into the platelet and coagulation profile and CBC, liver function tests, serum electrolytes, serum magnesium levels, uric acid, and blood grouping and typing should be done before any surgery. We can also look into the fetal surveillance, like fetal ultrasound, fetal growth, and uterine placental Doppler flow. Continuous fetal monitoring with the CTG should be done.
So this is a case of diagnosis, as you rightly said, has been given.
Yes, sir.
First of all, I want to know, have you seen a case of preeclampsia like the case scenario that has been described in your training period so far? Because in Miot, you don't have that much of exposure to OG cases, I know that, isn't it?
Yes, sir.
So have you had a chance to see a patient with preeclampsia being treated like this in your hospital?
Yes, sir. One case I saw, sir.
One case. Was it
Yes.
a case similar to this, like a very severe hypertension and edema?
Yes, sir. Severe uncontrolled hypertension, but she was having like systemic sclerosis also present, sir, and like autoimmune disease was there, and she had she was not like she was having the same BP about more than 190, 118, but not controlled with labetalol infusion, and there was fetal distress also, sir. So we did an emergency LSCS under GA, sir.
So what was the indication for GA in this case you managed? Why did you choose GA for regional?
It was an emergency LSCS, sir, due to severe fetal distress, and the gestation age was less than like 28 weeks, 28 weeks of gestation.
20 weeks.
28 weeks of gestation is, sir.
So the baby is very much premature.
Yes, sir.
Okay. Right. This sort of case scenario, when it is given, you need to know something more about the patient's condition, whether he had any previous seizure attacks.
Yes, sir.
If one seizure attack has happened and she has recovered from that, will you still call it as preeclampsia or will you call it as eclampsia?
Eclampsia, sir.
eclampsia. So as long as the patient has not thrown a fit, they will be treated only as pre-eclamptic patients. That is a very important point all of you should remember. So
Okay, sir.
our aim is to prevent eclampsia or fit occurring in a patient with pre-eclampsia. That is the first and foremost priority in these patients. Mother safety is very, very important more than fetal safety. Of course, fetus is also important. But when it comes to the question of choosing the life between mother and the child, if both are at risk, we must give priority to safeguard the mother's life rather than safeguard the fetus life. And what is the definitive treatment for preeclampsia?
Termination of pregnancy, that is delivery of the fetus and the placenta.
Delivery of the fetus and the placenta. Complete. Third stage also should be completed. Only then, is there a possibility that they can continue to have IBP postpartum also after delivery?
Yes, sir. Yes, sir.
What is that condition called? Continuation of preeclampsia in the postpartum period.
Okay, sir.
Nothing but continuation. So up to for 72 hours, they can have a chance to go and have a fit again. So it may not terminate immediately as we think, but the severity may not be that high as we expect. So it is always, you must watch them post-operatively also. Okay?
Okay, sir.
So this sort of case scenario, because it is given 34 weeks, and if the mother is going to, as you say, there is a fetal distress also in this case, and it is a very precious child. Mother has conceived after some infertility treatment, and they consider the baby as a very precious child, and the child is in fetal distress, and it is, but only it is 34 weeks gestational age. What
Yes,
will
sir.
you do?
We can give IV injection corticosteroids, betamethasone 12 mg,
Okay,
like 2 doses 12 hours apart for the fetal lung maturity, and
very good.
after that we can proceed with surgery, sir.
Excellent. So you have to make sure that the child will be able to survive because it is still not come to the stage of maturity. After 36 weeks, child will be definitely having a better chance of survival without any complications or neonatal intensive therapy. But at 34 weeks, there is always a possibility of lung immaturity, and the child may go in for the respiratory distress syndrome of the newborn. So we have to avoid that. So at the same time, we have to control the blood pressure in the mother and try to uh, keep her without going in for an eclampsia by prophylactic magnesium sulfate. When you have so many anti-epileptic drugs like phenytoin, barbiturates, why magnesium sulfate is the preferred drug for control of seizures or prevention of seizures in preeclamptic patients?
It can cross the blood-brain barrier and causes like a NMDA receptor antagonist, sir. So
Okay.
mainly act on the cerebral
That's a central and peripheral action.
central. Yes,
That
sir.
is the answer for that. Okay, exams they ask you this question: why you prefer to use magnesium sulfate when there are so many anti-epileptic agents? They will also give you an example. Supposing a patient with a brain tumor who has already had a fit, what drug will you give? Will you give magnesium sulfate or will you prefer phenytoin for that patient?
Magnesium.
The neurosurgical case,
Yes,
to
sir.
prevent epilepsy or a fit in that patient, will you give an anti-epileptic like phenytoin or barbiturate, or will you go for magnesium sulfate?
Phenytoin or treats.
Phenytoin, in those cases, that's the drug of choice. Whereas in preeclampsia, we prefer this because one, it has a dual action. It has a central nervous system action, as you rightly said, in controlling the NMDA receptor antagonism with glutamate blockade,
Okay.
as well as peripheral neuromuscular blocking effect, so that the muscles do not respond to the electrical stimulation coming from the brain. Okay? So
Okay,
that
sir.
is the reason why we choose it, and it has got a titratable dose, and we can give it as a continuous infusion for a constant effect. Instead of,
Yes, sir.
whereas the phenytoin and other barbiturates you can give only in the BD or TDS dosage. You cannot give them all those drugs as a continuous infusion. Whereas magnesium sulfate, you can have so many regimens are available. You know what
Yes.
are some names of the regimens that have been advocated for magnesium sulfate administration?
Pritchard's regimen, where
Pritchard.
intramuscular IM magnesium sulfate is given.
First
Zuspan's
bolus is IV, then
is
intramuscular.
loading dose 4 gram IV is given, followed by 10 gram, 5 gram in each buttocks IM, and following that 5 gram alternative buttocks over
Okay.
after every 4 hours. For 24 hours, we have to continue.
That
And
is
for
Pritchard.
yes, sir. For Zuspan regime, 4 gram IV loading dose is given, followed by infusion of 1 to 2 gram per hour for 24 hours.
Okay. Have you heard of Solapur regimen?
Yeah. Like 4 gram IV given, followed by 2 gram 2 gram IM injection in each buttocks.
Intramuscular. So the Suspan is totally intravenous. There is no intramuscular
Yes, sir.
initiation in Suspan. Whereas Pritchard and the Solapur, you give IV followed by intramuscular also. Okay. Why the earlier regimen of Pritchard preferred intramuscular rather than intravenous?
Difficult IV access, sir. Early
Really,
established.
it was actually preferred in patients who had very severe edema. It was one of the features of preeclampsia. So they were trying to securing an IV access was very difficult in those days when Venplan and all was not available. So they have to every time poke the vein and then give it IV, which was difficult. So they preferred to give it intramuscular in a large dose, which will get slowly absorbed and have a similar effect to continuous IV infusion by slow absorption.
Okay, sir.
What is the pathophysiology in preeclampsia? How does it cause these problems?
That will be abnormal placentation, sir, due to the tropoplast invasion. That won't be much tropoplast invasion in the deciduum and myometrium, and the vascular muscle tone uh, uh, will be that, sir. So the spiral arteries remodeling doesn't happen, sir. So the small caliber vessels will have higher resistance, and that will be placental ischemia, sir. And second, that may be widespread endothelial dysfunction due to the angiogenic factors, that is the soluble FMS like tyrosine kinase. They doesn't interact inhibit the interaction of the vascular endothelial growth factor and placental growth factor. So that will be endothelial dysfunction and nitric oxide. Due to that, there will be nitric oxide release, decrease in prostaglandin synthesis, and this in turn lead to capillary leak and further damage, sir.
So it is a two-stage procedure. That terminology you should use. So initial stage is placental abnormal placentation with the placental ischemia. That is the first stage. Then once the placenta fixation or placentation adherence to the myometrium has happened, then the endothelial dysfunction starts, which is called as a stage 2 of the pathophysiology of preeclampsia. In stage 2 only, there is an imbalance between the angiogenic factors and the anti-angiogenic factors. Because you have to form new blood vessels to take more blood from the mother for the survival of the fetus. That is a function of the placenta. So unless new vessels form, blood cannot be transferred from the mother to the fetus. So if the number of vessels that are formed are less, then again the ischemia will continue. Apart from the caliber of the vessel, new vessels also have to grow in the placenta when it gets adherent to the myometrium of the uterus. So this is considered as the second important factor or stage of the pathophysiology. Okay. So with this introduction, I'll just share you. It has got some type of question and answers presentation there.
Okay, sir.
We'll just will show you the questions, and you can, any one of you can try to answer, not necessarily only Priya, you can try to answer.
Okay, sir.
Is the screen visible?
Yes, sir.
Yes, sir.
Okay. So this is the case scenario. 24 weeks, patient is a primary, complaining of severe headache, visual disturbances. BP is roughly 190 by 120, and she has a teething edema also. Okay. Now the first question, what is your diagnosis of the patient? Already the case history, they have given that she has been diagnosed to have preeclampsia.
Yes, sir.
If they have not given the diagnosis of preeclampsia in the case history or the case scenario,
Yes, sir.
how will you diagnose preeclampsia in this patient? Is it only with the BP or something?
Presence of proteinuria, sir.
Presence of protein in the urine is a very, very important finding which should be present.
Okay, sir.
So that is the why the protein appears in the urine.
Due to endothelial cell damage, sir, and glomerular endotheliosis, sir. So the
Capillary leak
capillary
is there.
leak and
So
protein, sir.
you can remember the answer for this are any preeclamptic patient has a whole body capillary leaky system. Okay.
Okay.
So if he can develop edema in the periphery, if he can develop edema in the lung, if he can develop leaky proteins from the kidney. So all this is because of the capillary damage. Okay. Now, how will you proceed with the patient? You have answered that. Now, the next common question they may ask you is, what are the hypertensive disorders of pregnancy?
We have 4 entities, sir, like gestational hypertension, that is BP more than 140/90 in two or more occasions, like 6 hours apart, and it is getting resolved after pregnancy, sir, like 12 weeks after pregnancy. Gestational hypertension. Preeclampsia, the presence of BP more than 140/90 and proteinuria, or presence of any of one of the features like thrombocytopenia, elevated liver enzymes, that can also include in the diagnosis of preeclampsia. And chronic hypertension, those who are having hypertension before pregnancy itself. And chronic hypertension with superimposed preeclampsia is chronic hypertensive patient developing preeclampsia with the presence of proteinuria. Yes, sir.
Right. So the gestational hypertension, important point is he develops hypertension after how many weeks?
20 weeks of gestation.
20 weeks. All of them will have BP only after 20 weeks, except chronic hypertension patient who may have hypertension even before becoming pregnant. As
Yes,
a
sir.
married woman, before she conceives, she may be having hypertension for which she may be taking some treatment also. Then she comes under the category of chronic hypertension.
Okay.
Whereas patients who develop hypertension after, why this 20 weeks time is specified? Maybe always supposing he develops hypertension even the first 4 weeks, then we will brand them only as chronic hypertensive patients. But those who develop hypertension after 20 weeks of gestation only, we say that it is gestational hypertension. If it is associated with proteinuria, we call it as preeclampsia. Or if it is present even before that, then proteinuria, chronic hypertension, superimposed preeclampsia. Why the 20 weeks time is given for that?
Due to the placental
The complete implantation or placentation happens only completed at the 28th week of gestation. Okay? Until then, there is always a chance that the placenta may not stick properly. It may get denuded, and the chance of miscarriage is always there. Okay? That is the reason why we always say the first trimester and the early second trimester is very, very important in a pregnant woman's life to avoid any miscarriage, because the placentation is not complete until the 20th week of gestation. Okay? So if at all the patient has to develop the hypertension, it will happen after the second stage has been completed. The pathophysiology second stage happens only until 28th week completion happens. So all the reactive factors happening from the endothelium, they get the full establishment of all the changes happen after 20 weeks. So that is the reason why we always say 20 weeks is important. Now, under what category this patient comes? Based on the blood pressure and pitting edema, proteinuria, how do you grade the severity of preeclampsia? Is it based on the blood pressure?
Preeclampsia, there is only mild and severe preeclampsia, sir. This patient comes under severe preeclampsia category, and hypertension, it is like a severe hypertension, sir.
Severe hypertension. So how will you confirm your diagnosis? Of course, it is by proteinuria. What can happen if this condition is not treated immediately?
It can lead to complication like eclampsia, pulmonary edema,
Eclampsia,
intracranial hemorrhage.
Good. Right. How do you proceed to treat this patient? We have discussed. Depends on whether you need to deliver the baby immediately or whether you can allow the baby to continue to achieve some amount of more stability and maturity by waiting up to 36 weeks. That is the biggest dilemma in this case. Whether we have to deliver and save the mother immediately because of the high BP, pitting edema, and proteinuria, and so the headache and visual disturbance is a indication that the central nervous system is also getting affected. So our aim is to, as you rightly said, admit the patient immediately. That is the answer expected out of you in the examination. If such a case scenario is given or such a patient, live patient is kept there, you must always say patient cannot be treated as outpatient. They have to be admitted immediately and blood pressure has to be brought back to normal by intravenous antihypertensive. The two drugs of choice, as you rightly said, is labetalol and ibuprofen. That can be started, and we must gradually bring down the blood pressure. We should not try to bring down the blood pressure from 190 to 120 immediately next second hour or third hour. You should not bring it down to 110, 70. Hey, what will happen if you reduce the BP so drastically?
That will be alteration in the autoregulation, sir. So there will be ischemia and can lead to myocardial end organ damage.
Yeah, so it is a cerebral autoregulation is also reset in these patients because of the chronic elevation in the BP. A sudden reduction from a very high BP to normal levels of 120, 80 or 170 will not allow time for the autoregulation to be adjusted in the central nervous system, which may cause cerebral complications or central nervous system complications. So we must aim for reduction of 25% of the first recorded BP every hour, not more than that. Okay. So gradually titrate the drugs and try to bring it down. So the whole blood pressure can be brought to normal within about 4 to 5 hours, not immediately in the second hour of admission itself. Okay. And during all this time, you should also monitor the safety of the fetus by fetal monitoring. What are all the tests that you can do for fetal monitoring? What is the simplest test that indicates that fetus is doing well?
Fetal movements.
Movement, very good. So the mother will have to say that she is able to feel the fetal movements. That is very, very important. Then you can check the fetal heart rate, which are all easily done at the bedside itself with the stethoscope. Or you can attach what is the instrument that you can use to monitor the fetus?
CTG, cardiotocography, sir.
Cardiotocography, very good. That can be attached and you can measure the heartbeat of the child and see. So what are the response of the fetal heart to if she has started developing a labor contraction? What are the responses of the heart and how do you describe that fetal heart response? What are the various decelerations and accelerations? How do you describe that? Soundarya,
Sir, not able to recollect, sir.
not able to recollect. Okay. So when the mother goes into labor and the uterus starts contracting, and if the patient, the fetus is in the vertex position, that is, the head is going to come down, then what will happen? The uterine wall will apply pressure on the fetal head. So this will cause initially a rise in the pulse rate because the baby is being stimulated with the pressure of the uterus. Okay. So the heart rate, which is normally about 120 to 130, will initially increase once the compression is applied to the fetal head. This is called early acceleration. Okay? And this is a good sign that the baby is responding in the normal physiological way because it is getting stimulated. During this time, supposing the umbilical cord is around the neck of the child, and this compression not only compresses the fetal head but also causes a compression in the umbilical cord. What will happen to the blood supply?
Decreases.
Sir.
It will decrease. When the blood supply decreases, what will happen to the oxygenation?
Decrease
It
hypoxia.
will also decrease because that baby cannot increase the heart rate for hypoxia until it is born, and even after delivery and birth. We saw in the last class or earlier classes, even in the neonatal and the infant period, up to 6 months till the sympathetic system fully develops, patient will have predominant parasympathetic activity. So once the cord around the neck is there and it is getting compressed, then there will be a deceleration or the heart rate will go down. So early acceleration is a normal response to the pressure on the scalp of the child. But if it continues to go into deceleration or bradycardia, it indicates fetal hypoxia, probably because of the cord around the neck causing hypoxemia in the baby. Okay? So this is how you try to monitor the child and try to take a decision whether you can allow the normal vaginal delivery or whether you have to go for immediate cesarean and try deliver the baby to prevent any further damage to the. So this deceleration, if it goes on getting prolonged, the bradycardia becoming lower and lower after the initial tachycardia, that is a bad sign that the child is becoming hypoxic. Okay. And so this is the way you can manage. 3 simple ways of monitoring the fetus are fetal movement, then the fetal heart rate, whether it is normal or not, and if the mother has started going into labor, the fetal acceleration, heart rate acceleration and deceleration. These are the simple things that you can remember to assess the severity of the or the wellness of the fetus. The next question is, can pregnancy be terminated at this stage? If yes, what are the advantages and disadvantages? No, remember, she is only 34 weeks now, gestation. Huh?
The fetal lung won't be not mature.
Fetal lung maturity will be low, so that is a disadvantage of delivering for the fetus. But
Yes.
if the mother's life is in danger, if the blood pressure is not coming under control with the antihypertensive treatment that you give, and her visual disturbance and headache is getting worse, that means the blood pressure is, the circular nervous system effects are getting more severe. So it is better to terminate the pregnancy and deliver the baby as early as possible. Okay? So that is the, but if you deliver at this stage, there is always a risk for the fetus to have a immature lung. So if at all can buy some time, as you rightly said, you can try intravenous dexamethasone, 2 doses at least minimum of 10 milligram IV before you deliver the baby for allowing some amount of improvement in the lung function of the fetus. Okay? That is the answer that you have to give. If planning to allow pregnancy to continue, what are the advantages and disadvantages?
There will be less fetal complication, neonatal complication in the
Very
baby.
good. So it is safer or better for the baby to reach at least 36 weeks of gestation. Okay?
Yes, sir.
But and if the blood pressure and the headache, everything resolves by the treatment with antihypertensive, that's a good sign that mother is also responding. So
Yes,
in
sir.
that case, you can safely continue the pregnancy without thinking of terminating it at this stage. Now, if physician wants to try normal delivery because the fetus is of normal size, mother's pelvic measurements are all normal, there is no cephalopelvic disproportion. So the physician feels that the mother can have a normal delivery. In that case, what is your role as anesthetist in this scenario?
Uh, we can give a like epidural and labor anesthesia.
Here is where you come to help the physician with the labor analgesia for the patient so that the pain of the labor, which can, what is the risk of allowing the mother to feel the normal labor pains in this
that
case?
we rise in BP, hypertension.
It will further worsen the hypertension, and even if you are trying to get treated with antihypertensives, it may not be fully effective because the pain is being perceived by the mother, which will stimulate the catecholamines in her body, and that will cause a further increase in BP. So all your efforts to bring it down by IV labetalol or your hydralazine may not be fully satisfactory. It may get nullified and BP will again shoot up, and there is again a risk of cerebral or cardiac complications happening will be very high. So we have to block that pain sensation by adequate and good epidural analgesia. And then if the physician wants to go for a normal vaginal delivery with her patient, then she can safely have a normal vaginal delivery if the other parameters are okay. Okay. So how do you administer epidural analgesia? What are all the contraindications for giving an epidural labor analgesia in this patient?
Patient refusal, sir. Any infection, thrombocytopenia of platelets less than 70,000, altered coagulation profile,
Very good.
And local infection at the site.
That you have already said. Supposing patient has got severe anasarca, is bloated all over the body. Will it be technically easy?
Difficult, sir.
Difficult. In that case, nowadays, what gadget you can use to achieve a good location of the epidural space and threading a catheter there?
Ultrasound.
You can use an ultrasound to locate the midline and try to use it for introducing your tubby needle. So, if supposing patient is obese and has got edema all over the back, what precautions or what preparations you will make to before you think of giving epidural block for labor analgesia? What are the important changes that you require in the instruments or gadgets that you use? Will you be able to reach the epidural space with the normal 2T needle that you use for a regular patient?
Lengthy needle, sir.
You need a extra large or extra length of a needle. Okay? You cannot reach them with a normal. What is the normal length of a 2T needle that you
8
use?
centimeters, sir.
8 centimeters. So that is the thing that you have to keep in your mind. And so the extra large needle, extra long needle will be required. You may require ultrasound to locate the space. Then you may need a proper help for the to hold the patient or position the patient before you think of giving the silence. So without all this preparation, you should not haphazardly try to locate the space and give the block. Okay. So that is the important thing that you have to remember in this also. So you can give a labor epidural and allow the vaginal delivery to happen if other parameters are okay, other conditions are satisfactory. But if you are planning for an elective operated delivery, how do you manage? supposing your labor catheter, I mean epidural catheter is in place, and you have successfully given a labor analgesia, patient is pain free. Have you, any one of you done a labor epidural
Yes, sir.
or train? You are done. Okay. What is the concentration and what is the volume that you give in the first place after inserting the catheter?
For epidural lumbar, for epidural analgesia, we'll give 0.0625, sir. If in elective operational delivery, before 20 minutes, I will give lignocaine with adrenaline for 10 ml and
0.0262
6 to 5% of.
what is the volume you will give? You are saying the concentration, but
Okay,
what
sir.
is the initial volume you have to give and
12
how?
ml. Sir,
5
first I
ml.
will. Yes, sir.
Yes.
First, I will check for SLRT test. Our patient can move like that test we have to do, sir.
No, first low bolus dose is always for 3 to 5
Yes, sir.
ml, depending upon the height of the patient.
Yes,
Then
sir.
to check the level, and then until you achieve a level of more than 2.8, that you can go on giving aliquots up to 3 ml
Yes,
to
sir.
achieve that height. And then this should not produce any motor blockage.
Motor
Okay?
blockage, sir.
So examiners may ask you about the test dose. How do you check whether the catheter is in place? What is epidural test dose? How do you perform that? That is a
Every
common
dose
question.
is a test dose in pregnancy, sir. So, sir.
No, when you put any labor catheter, epidural catheter for continuous pain relief, you are supposed to do a test dose to see whether the catheter is in proper place without migrating into a blood vessel or a subarachnoid area. That is the main important difference that we have to make. So how do you perform the epidural test dose?
3 ml, sir.
3 ml of what?
1.5% lignocaine, sir.
Lignocaine with
With
adrenaline.
It's
how
adrenaline,
much
sir.
of adrenaline should be there? All these things
1
are
in 2 lakhs.
details we have.
1 in 2 lakhs.
1 and 2 lakhs. How many ml?
3 ml, so
3
50 mics will be there. sir.
So you must say all these things. It's a 3 ml volume, 1.5% xylocaine is there in that. 1.5% means how many milligrams per ml?
60, sorry, 62,
15.
sir.
1% is 10 milligrams. So
Yes, sir.
1.5% is 15 milligrams. So 3 into 15, total 45 milligrams of xylocaine, and 1 in 200,000 adrenaline, which is 5 milligram per ml. So 3 ml, it will be 15 milligram of 15 micrograms of epinephrine also. Okay. So 3 ml volume, 1.5 xylocaine, 1.5% xylocaine, which will make a total of 45 milligram of xylocaine, and 1 in 2000 adrenaline, which is 5 microgram per ml. So 3 into 5, 15 micrograms of epinephrine. This is the composition. So you first inject that into the epidural space and make sure that patient is not having any motor weakness or tachycardia. Okay. So tachycardia of more than 20 beats per minute from the baseline is indicative of intravascular placement. Motor weakness indicates it is subarachnoid or it is mixing with the CSR. So this is the answer that you have to give for how do you perform the epidural test dose. All these details you have to give. Are you clear?
Yes,
Yes,
sir.
sir.
Okay. Right. Now, how to evaluate this patient? How do you assess the fetal welfare? Of course, we have done that. What are the investigations? Evaluation means what are all the investigations you have to do with this patient?
It's CBC, coagulation profile,
Ah,
serum electrolytes, LFT,
electrolytes.
Urine routine.
creatinine, uric
Yeah.
acid, and magnesium
acid.
levels. sir.
Okay.
And
So these
glycogen.
are all the basic investigations and cardiovascular assessment. And, make sure that the renal function is also normal. So that is a very important point that we are doing. Of course, with fetal welfare also we have talked about just now. So what prior preparations are needed to safeguard the fetal welfare? If it is delivered at 34, of course we have talked about the lung maturity with the steroid. What are the drugs used in the treatment of the condition of the mother? That also you have described antihypertensives and the preventive or prophylactic anti-seizure medications like magnesium sulfate. What are the various regimens used of magnesium sulfate in preeclampsia? That also we have discussed. How to monitor during magnesium sulfate administration? What are the effects during increasing blood levels? Okay, so this is the, sorry, one second. Ragulu, class இருக்கேன், அது important. So this is the so the common question they ask you is what are all the what is the safe magnesium serum level, therapeutic level,
Yes, sir.
and varying increasing levels, what are all the changes they will produce? That is a very commonly asked question. So what is the safe limit of magnesium therapeutic level?
8 to 9
How many?
milligram per
4 to
deciliter.
7, sir.
4 to 7
Therapeutic is 4
milliequivalents per liter. Very good. So above that, what is the first thing that will get affected?
Patellar reflex.
Patellar reflex will not be present or it will be sluggish. Very good. Then
If
what
less
is the
than
next
10
step?
Respiratory paralysis.
You will
And
have
then-
more than
10 to 12 respiratory depression, sir.
respiratory depression and
If
More than
12 to
30 cardiac arrest.
sir.
cardiac arrest. Very good. Right. So how to, supposing by mistake magnesium overdose has happened, how to manage that?
If you
Stop
stop
the-
them, give
First you stop
IV
the further infusion. Excellent. Then
give IV injection of calcium gluconate 10% 10 ml over 10 minutes, sir.
10 minutes. Okay, that is the immediate treatment because calcium is the antagonist for that. And if the patient has also some renal problem,
Dialysis,
then
sir.
dialysis,
you
sir.
have to go for elective dialysis to remove the pressure. So, and you have to adjust the dose if patient already has a compromised renal function. You have to be careful, not the usual 4 gram loading, 2 gram following, all that should be very much reduced depending upon the GFR. Okay, that is a very important point that has to be taken care of. Then how to manage normal vaginal delivery in this case? Of course, with a good working labor epidural, we can do that. Which regional anesthesia is suitable for cesarean section in this patient and how it is administered? Supposing this patient with a BP of 190, 120, despite your antihypertensive treatment, BP is not coming down, the headache is becoming severe and fetal distress is also happening, and you want to give a single shot spinal. How will you do that? Will you give the regular dose of 2.5 ml
Low dose.
of 0.5% heavy bupivacaine that you give for your normal vaginal and labor cesarean sections, or will you modify that?
Low dose.
Spinal, sir.
Low dose. So what do you mean by low dose? How do you give? What exact volume you will give?
1.5 to 2 ml, sir. 2 ml of
1.5 to 2 ml means of 0.5% bupivacaine heavy. Only that you will give, or will you have any additive to
adjuvant,
that?
sir, along with the adjuvant, sir. Fentanyl
So
adjuvant.
instead of giving the regular 2.5 ml that you give for a normal cesarean section, here you take only 1.5 ml of 0.5% bupivacaine heavy, to which you add 0.5 ml of fentanyl, which will contain 25 micrograms of fentanyl. Okay? So a total volume of 2 ml can be given. So 1.5 ml bupivacaine, 0.5% heavy plus 0.5 ml fentanyl. So total volume will be 2 ml. That can be administered at L2, L3 or L3, L4 phase. And depending upon them, so what will happen to the height of the block in pregnant women?
It will increase due to the absence of lordosis, the spine curvature,
Abdominal pressure.
and increase
And
abdominal.
also the CS of pressure is there increased because of the compression by the gravity uterus. So normal tendency is for the height to increase more than the non-pregnant woman. So you have to be very watchful in positioning the mother correctly so that you don't achieve a too high a block. And so this is the adjustment that you have to make in the dosage of the drug if you want to give a single shot spinal for this patient in this situation. If GA is needed, how do you administer that? You said you managed your patient with GA, the case that you had an exposure with preeclampsia.
Yes,
You
sir.
said because of the fetal distress, you administered GA. Can you recall and tell me what are all the drugs that you used and what are the steps, how you manage the practical method of managing a GA for cesarean section?
We gave pre-medications like H2 blocker was given before, sir. Then induction, we gave Midas 1 mg, sir. We avoided opioids, but low dose opioid was given, sir. But due to 28 weeks of gestation and poor fetal distress, we gave low dose opioid after consulting with the pediatrician, sir. Then we induced a rapid sequence induction, sir. We gave rocuronium as a muscle relaxant, and we intubated the patient with 7-size ET tube, sir. First we went for 6.5, but no edema was there, sir, and we can clearly hear the leaks, sir. So we took the ET 6.5 tube and went for 7-size tube and intubated the patient, sir. There was not much intubation response was seen, sir. So following that, we gave after the delivery of the baby,
What was
we
the
gave
induction agent you used? You didn't say that.
Midas and
Only
propofol.
Midas and the straightaway
No,
rotronine?
no, sir, propofols.
Propofol you gave.
Yes,
What
sir.
about pre-oxygenation?
Yes, sir, we did, sir.
Don't forget that at all in the examination. In any pregnancy patient, if you don't start pre-oxygenation as the first step before doing GA, your career will be finished. Okay? The examiners will never forgive you for that. Okay? It's very, very important to remember specifically and mention that I will first pre-oxygenate. However emergent the situation may be, you always say I will pre-oxygenate. Then they may ask you different types of pre-oxygenation. Supposing they say that fetal heart is going down, it is only at 60, 70, and position is in tense mode. So will you take 3 minutes to pre-oxygenate? Will it be the ideal thing that you can do? Then you can say what are all the other alternatives for the regular 3-minute tidal volume pre-oxygenation? What are the other alternatives for that?
Paroxysm.
No.
Other hand. Nasal prongs.
Nasal prongs. No, other techniques of pre-oxygenation.
Vital
Apart
capacity.
from
Nasal capacity.
the 4 vital capacity breaths. Ask the patient to inhale deeply and exhale deeply. Just like you are measuring your vital capacity with that, when you do the spirometry, you can ask the patient to take 4 vital capacity breaths. That will take hardly 1 minute. So you can reduce the time and achieve the same thing. And nowadays we always say that you can have the nasal prongs with 6 liters of oxygen going on for the apneic oxygenation technique, so that you can avoid intraoperative or the intubation time apnea, hypoxia can be prolonged without desaturation. Okay? So that is the answer that you have to remember and tell the examination. So no, don't forget to say I will first pre-oxygenate the patient, then give all these drugs IV, and then intubate the patient. If the patient is having a high BP like this 190, 120, not responding to antihypertensives, then you have to give Xylacard, you have to give Esmolol, and try to control the shoot up in laryngoscopy in intubation response. That is also expected out of you. Because the case you handled did not have that much high response or high BP, you manage without that. But in the exam, if the scenario says that BP is still high, always try to give or suppress the sympathetic response to laryngoscopy and intubation in the routine manner that you do for by xylocard and beta blockers. Okay, that has to be always remembered. And what post-op care is required in these patients?
Adequate analgesia, continuous
Very good.
monitoring of the patient for BP, and to look out for seizures.
So observation for up to 72 hours. So, and sometimes you may have to continue magnesium sulfate in the post-operative period also. Okay. Apart from good analgesia, good monitoring for oxygenation and other parameters, and continuation of magnesium sulfate if there is a patient's headache and visual disturbance continue, you have to continue magnesium sulfate in the post delivery period also. Okay, so these are the important things. So quickly, I'll go through the other slides in this preparation. So they may ask you, how do you define PAH? Because we have seen that after pathophysiology, clinical presentation, decision making in these cases, monitoring and management, pre-op investigation, delivery management, complications and the management of the complications, and what are all the allied topics from which questions can be asked in the examination is also very important in this. Because when 4 or 5 of you go for the same center, they may not ask again and again the management of cesarean section or magnesium sulfate. They may ask you about the physiology of pregnancy. They may ask you about anemia complicating pregnancy. They may ask you other pregnancy related conditions, and so that the questions will be different for different students. So I will tell you what are the allied topics you have to keep in mind. So definition is new onset hypertension. If you have to say it is a pregnancy-induced hypertension or preeclampsia, it has to be a new onset. Patient should not have been an hypertensive before she became pregnant, and it occurs after 20 weeks of gestation. Okay, and this is the classification which you mentioned that we have seen already. Preeclampsia is after around 20 weeks with proteinuria. Gestational hypertension onset after 20 weeks but no proteinuria. Chronic hypertension onset before 20 weeks or even before pregnancy, and chronic hypertension superimposed with preeclampsia, that is with proteinuria, but the onset is before 20 weeks, then it is coming under the fourth category. Now, what are all the types of pre-gestational hypertension? That is, without proteinuria, if the patient has got gestational hypertension, the types are, it can be a primary or secondary hypertension, like any hypertensive patient when you want to do that. And white coat hypertension. Then masked hypertension. Do you know what is this masked hypertension? Yeah.
It will be normal in the hospital, but at home it will be high.
Ah, very good. So this is a very opposite to white coat hypertension. In white coat hypertension, it is BP is high in the hospital, or whenever the doctor or nurses take the BP goes up. But at home or other convenient environment, BP is normal. So how to prove it is white coat hypertension? Every time when the patient comes to hospital, the doctor or nurse takes the BP is always 150, 100. But when they have a BP monitor at home and they take it, they say it is 120, 80. So how to prove that it is purely white coat hypertension and not pathological hypertension? You have to do continuous ambulatory BP monitoring, like Holter monitoring. Okay, that only can prove that the home BP is normal, and you can the BP shoots up only when the patient comes to the hospital. So the definition actually given in the FRCA textbook is white coat hypertension is a abnormally elevated blood pressure in the hospital setting, but a normal blood pressure in home ambulatory blood pressure monitoring. That is the definition of white coat hypertension. Whereas the masked hypertension is the opposite of that. When you take the BP in the hospital, it is normal, but when it is measured at home or other locations, it is high. So when an individual's blood pressure readings are normal during medical check at the doctor's office, but are elevated at home or in other environment, that is called the masked hypertension. And HELP syndrome is the extreme degree of the spectrum of preeclampsia. So it is a variant of eclampsia. It has got four components: hemolysis, elevated liver enzyme, low platelets, and three components. And this is the term coined by Weinstein in 1982. Pathogenesis, which is always mentioned in the exam, it's a two-stage process of pathogenesis. In stage 1, it is abnormal presentation and vascular remodeling. So the second stage is the so the second stage only all the vascular changes that happen, excessive anti-angiogenic factors like soluble fragment like tyrosine kinase, which becomes predominant. So in this picture, if you see, when there is a vascular endothelial growth factor and platelet-induced growth factors are there getting attached to what is called the specific receptor for that, it leads to formation of new blood vessels. Angiogenesis happens. On the contrary, these growth factors, if they get attached to this SLFFT1, then this blocks the angiogenesis and new vessel formation is not there. So here also it is a nice picture to remember two-stage theory of preeclampsia. So first stage is abnormal placentation leading to placental hypoperfusion. This results in second stage where endothelial dysfunction happens because of the increase in the soluble fragments like the tyrosine kinase, which blocks the effects of vascular endothelial growth factor and the platelet-induced growth factor, which goes on to produce systemic vascular dysfunction. So after the effects happen in the placenta, it gets transferred to the entire vasculature in the body of the mother. So it leads to systemic vascular dysfunction, leading to contracted volume, contracted. So this picture will nicely show you what is the first stage abnormal placentation. This is the maternal myometrium. This is the decidua. This is the placenta. So in a normal pregnancy, the so-called spiral arteries, which are the arteries branches of the uterine artery coming in connection with the placenta, they lose their lining muscular cells. That is called the remodeling. So the trophoblastic invasion removes all the smooth muscles in the vasculature and make it a simple conduit for blood to flow without any blood pressure. That is why placental circulation has got no auto-regulation. Okay, so this is one of the conditions where there is no auto-regulatory pressure here, so that all the time blood can flow easily. Whereas in preeclampsia, this muscle coat is not removed, so still it becomes a sensitive or a resistive vessel, so it contracts and dilates without allowing too much of blood to flow, leading to ischemia. So that is the failure of conversion of small caliber resistant vessel to large caliber capacitance vessel, which happen in the normal, does not happen in this patient. In the stage 2, you can see all these changes happen in the endothelial lining, vascular smooth muscle, everything leading to the imbalance. The net effect of that is vasospasm, capillary leak, and activation of coagulation factor. So these are all the things that change. So of course these are all the same thing. And there are two stages of preeclampsia, and there are two timings of preeclampsia happening. One is called early onset preeclampsia, and the other is called late onset preeclampsia. How are they differentiated? So early onset preeclampsia occurs before 34 weeks of gestation, and it is thought to be primarily caused by the in situ trophoblastic stress leading to poor placentation, whereas late onset preeclampsia sometimes happens at or after 34 weeks, and it is understood to be secondary to the placenta outgrowing its own circulation. So early onset preeclampsia is more frequently associated with fetal growth retardation than late onset preeclampsia, where there is a longer duration of placental dysfunction. Okay. And what are the grades and symptoms of hypertension? Grades: mild hypertension is 140 to 149, moderate, severe, and very severe preeclampsia. Symptoms are headache, visual disturbance, abdominal pain, nausea, vomiting, sudden swelling of face, feet, and hands, risk deep depth tender reflexes. And the effects of systems involved in the preeclampsia: various systems. First, hematological, you may have thrombocytopenia, which lead to altered coagulation, which may result in this HELP syndrome also. Biochemical impairment: kidney will be affected, altered urea, creatinine, sodium, potassium, and protein elevated urine PCR. So liver, there may be low albumin and low glucose, elevated liver enzymes, and the useful investigations that you can do in preeclampsia are full blood count, with emphasis on platelet count, coagulation screening, request for peripheral smear, which may show spherocytes, histiocytes, and triangular cells and Barr cells. If it is HELP syndrome is suspected, you have to do a peripheral smear study. And urea and electrolytes may be altered. Liver function tests also will be altered in HELP syndrome. And urine diptych test for the proteinuria that is happening. So urinary protein creatinine ratio from a random sample more than 30 milligram per millimole does not reliably confirm the quantity of proteinuria, but that is the normal thing, minimum that should be there. And more than 300 milligram in 24 hours is confirmed as a significant and a very important diagnostic clue for preeclampsia. And you should always take the midstream specimen to exclude any infection, and urine output must be accurately monitored and recorded. Once you have a heavy proteinuria, you must always routinely monitor the urine output in these patients. Ultrasound, which is useful in not only preeclampsia, nowadays in all pregnant women, it's the airway evaluation. Second is the gastric volume measurement. Third is the vascular axis. Fourth for lung field assessment. And fifth for optic nerve sheath diameter to see whether there is any cerebral edema. And in neuraxial blockade, obese or a patient with back edema, you can use that. So these are all the uses of ultrasound in pregnant women. What is this Rose scan? Any idea the expansion of the Rose? Yeah.
Rapid obstetric screening of echocardiography.
Screening echocardiography. Okay. So, and how and why is this done?
To look for fluid status and obstetric peripartum cardiomyopathy, sir.
Very good. So performed using transthoracic echocardiography to assess fluid status. Okay. Pregnancy associated factors. Of course, these are all the etiological factors for the occurrence. This is more for theory exam. You have to write all these things. And life-threatening complications are hypertensive crisis, pulmonary edema, eclampsia, and what is Sebae's criteria for true or complete HELP syndrome?
LDH more than 600, sir, and AST more than 70. Thrombocytopenia.
Abnormal peripheral blood smear. That's why I told you you must do a peripheral smear for spherocytosis site. On the earlier slide I showed you, which is the first thing. Bilirubin more than 1 to 2 milligram, LDH more than 600, AST more than 70, platelet count less than 1 lakh. So these 5 things constitute what is called Sebae's criteria for diagnosing true or severe Cleft syndrome. Complications of preeclampsia, the maternal can have cardiovascular complications, generalized vasoconstriction, decreased circulating volume, LV failure, increased vascular permeability and edema. The nervous system, you had headache, visual disturbance, vomiting, confusion, etc. Cerebral hemorrhage is a common pathophysiology due to which death occurs in preeclamptic women. So, majority of them were diagnosed by postmortem findings in the earlier days. So, you have to be very watchful in these patients. If they suddenly become unconscious, you have to suspect cerebral hemorrhage. And convulsions due to cerebral irritability also. And respiratory system, generalized edema, enhanced upper airway edema, non-cardiac pulmonary edema because of the capillary leakage that can happen. So, because most of them are young women, there is usually not cardiac failure is not the reason for that. And even if they have hypertension, it is of short duration. So, that much of LVH and cardiac failure cannot happen within that 4 to 6 months of hypertensive period. So, that is the main reason is capillary leak. And renal system can affect all these things. Liver, because it can, hematology can get all these changes. And in the fetal complications, decreased placental perfusion, placental ischemia and infarction, and patient may be small for the age or the period of gestation, and sudden placental abruption and preterm labor are all common in these things. And these are more common in the early onset preeclampsia, which occurs right from 20th week of pregnancy. So controversial areas is clinical management. If preeclampsia develops at early gestation, when and how it will be tackled that? When is invasive monitoring needed in these patients? What are the benefits and risks of various antihypertensives? So their side effects. How should we manage an eclamptic seizure? Supposing patient has had a fit, a known preeclamptic patient has thrown a fit when they are 34, 36 weeks pregnant. How do you manage that?
We should give magnesium, sir. Magnesium sulfate to
No,
control the
patient is
seizures.
convulsing now. You are in the ward and patient has become there's a seizure activity going on. You are standing next to the patient. What are all the things that you will go? Already patient has been treated with magnesium and other things.
First, protect the airways, sir.
Airway management,
Ah,
Repeat the question.
lateral position. Yeah, patient
Yes, sir.
should be in the right or left lateral. Extend the head, clear the
Call
airway,
for help.
suction any secretions or anything. That is the first answer. Try to give oxygen and try to increase the dose of magnesium sulfate. Okay? And magnesium, why magnesium is preferred over other anti-seizure medication? How we manage fluids? So fluid management in the preeclamptic patients. What are all the precautions we have to take?
That should be restrict to co-loading, sir.
Ah.
And fluid about 1 ml per kg per hour should be given. And urine output also should be assessed. If it should be more than 100 ml over 4 hours, sir. That should not be
0.5 ml per
0.5.
kg per hour.
Okay, sir. Okay, sir.
Blanket 100 ml, you can say 0.5 ml per kg per hour of urine output is expected. Okay?
Okay, sir.
Platelet count, what is the safe value for neuraxial block?
More than 70,000 according to ACOG 2019 guidance.
Yes. Earlier it was 80,000, now they reduced to even 70,000. And patient should not have any bleeding tendency. Supposing patient has 1.5 lakhs platelet, but wherever you try to secure an IV line and all those sites are bleeding, then it is not a suitable candidate for, just because platelet count is 1.5 lakhs, you cannot risk the patient with a central neuraxial blockage. So even lower the count with no indication of abnormal bleeding profile, and in clinical bleeding is very important. And
Yes,
is spinal safe in severe preeclampsia?
yes, sir.
Yes, but with modified, what I told you, instead of the regular 2.5 ml, you can modify the dosage and give that. And should phenylephrine, uh, should phenylephrine replace ephedrine to treat hypotension?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yeah, that is the drug of choice, phenylephrine. And only cure for eclampsia, as we said, is delivery. So you must always take into consideration maternal versus fetal safety and maturity of the child. So gestational hypertension, mild preeclampsia can be managed at home with frequent monitoring and fetal surveillance. Severe preeclampsia needs admission. And if a patient has what is called a favorable cervix with a good dilatation and fetal maturity, you can go for normal vaginal delivery with proper pain relief. But patient is not dilating properly, unfavorable cervix with adequate fetal maturity, better to go for elective cesarean section rather than allowing a normal vaginal delivery. And if the child is fetus is less than 34 weeks with severe preeclampsia, delay delivery for 48 hours to administer steroids for fetal lung maturity. But if there is any risk to the mother, this should not take priority. You don't have to wait. You can straight away go and manage the baby in the neonatal ICU if they develop any respiratory issues. But mother safety should never be compromised. And magnesium sulfate infusion and IV antihypertensives for a BP of more than 170, 110. HELP syndrome treated with large doses of dexamethasone 10 milligram BD. So that is the additional treatment that you have to give if the patient mother is having HELP syndrome. And the dilemma in the treatment of hypertensive cases, maternal complication versus fetal safety compromise. So high BP, the complications that can produce are pulmonary edema, cerebral hemorrhage. High systolic BP can cause stroke and bleeding. So invasive monitoring is rarely needed since most of the mothers are quite young with a fewer chronic illnesses. But what are the conditions where arterial line is indicated in preeclamptic patients? Can you mention a few indications for putting an arterial line, invasive monitoring?
Sir, uncontrolled hypertension, even not controlled with both levital or hydralazine, and requires monitoring, sir. An obese patient, BP cuff not adequate. ABG, for ABG.
Frequent ABG, pulmonary edema.
Pulmonary
Patients with BP more than 160 where IV vasodilators are not effective and who have coagulopathy and need frequent sampling. Those who are obese and who are severely edematous, if there is pulmonary edema and frequent ABG is needed, then in all these patients you have to put in an arterial line. The role of central venous catheterization and PA catheterization is are not normally used because of the risk of bleeding, need for trained nurses to manage the central line, but they are indicated if the patient has a cardiac failure, pulmonary edema with a large AA gradient, and oliguria despite fluid resuscitation. In these conditions, you can definitely think of that. So these are all the various drugs. Methyl-dropa was the earliest drug that was used. Sometimes examiners may ask you for historical reasons. The oral dose was 250 milligrams, 3 grams, up to 3 grams. But it is a central nervous system sympathetic blocker. False neurotransmitter to norepinephrine. Side effects are partial hypertension, sedation, depression, all these things. It is contraindicated in liver disease and the risk of postnatal depression is very high. But no more used. Sometimes asked for the historical interest in that. Labetalol, the drug dosage, everything we said. The side effects are bradycardia, fatigue, bronchospasm, and GI tract disturbances. Contraindications, patients with asthma, you should not give, or patients with cardiac diseases or pheochromocytoma, better to caution these patients. And drugs management continuing, ephedrine is the commonly used drug for all these patients. The next common is hydralazine, which is given mostly IV only, and alpha blockers, prozosine also preferred. Beta blockers are also given. Diuretic, magnesium sulfate. Magnesium sulfate is given not only for prophylactic prevention of seizure, but it's also having an antihypertensive effect. That's another advantage of that. And mention the prevention and control of seizures. Prevention is IV magnesium sulfate 4 grams IV bolus over 10 minutes, followed by 1 to 2 grams until 24 hours post delivery. This maintenance dose is stopped or decreased to 0.5 gram per hour if the patient is oliguric or if the serum magnesium level is higher than the therapeutic range. So in the event of recurrent seizures, further bolus dose of 2 to 4 grams can be given. The further seizure occurs despite the above informed in the intensive care, as additional seizure treatment may have to be thought of with airway support and ventilation. And so this is the prevention. Actual manage, of course, this is the various regimes of magnesium sulfate which we discussed already. Richard regimen, Ruspan. The Solapur regimen, initially 4 grams IV, followed dissolved in 20 cc of normal saline, given over 20 minutes. This is followed by 2 gram intramuscular every 3 hours in alternate capacity. So unless the 10 gram and 5 gram in Richard, it is only 2 grams every 3 hours. And the presentation of magnesium sulfate is available as 50% and 25%. 5 ml and 2 ml ampules are vials, and the ready-made solution, so you can use that and straight away use that, dilute it according to the requirement. And management of the patient throwing fit is administer high flow oxygen despite patient may be convulsing. Turn the patient to full left or right lateral. Introduce a bite block. Suction and clear the secretions. Small doses of tipentone and propofol can be given in case if it is not getting controlled with medication alone. Additional 2 gram magnesium. CT MRI if seizure is recurrent or rule out cerebral hemorrhage. Consider early delivery induced or you can allow induction if other parameters are okay with a good epidural, or you can go for a LSCS as planned. Now, fluid management, 2 changes that happen in preeclampsia are the contracted vascular tree. And the second thing is the leaky capillaries causing pulmonary edema. So it is safe to err on the side of less fluid intake. So maintenance fluid should not exceed 1 ml per kg per hour. Urine output of 0.5 ml per kg hour, which is accepted as a minimum. Or 2 ml per kg over 4 hours is also. Supposing every hour there is no urine output, you can take the total volume after every 4 hours, which should be at least 2 ml per kg within the 4 hours time. And co-loading is preferred to preloading during continuous airway blockade. The strategies in delivery patients with PET are time and mode of delivery is dependent on severity of the condition and gestational age of the fetus. These are the 2 things that you take into consideration. And delivery depends largely on maternal rather than fetal well-being. That has been the point I have been repeatedly. Mother's safety is always the priority. Anesthetic consideration, choice of anesthetic means for cesarean include regional technique is preferable in most cases. Hemodynamic stability following spinal anesthetic is comparable to epidural also. So subarachnoid block is earlier it was thought taboo. During our PG days, if we say I will give a spinal for preeclampsia patients, we will be failed and sent home. But later on, textbooks themselves have started saying that you can safely administer, because earlier they thought the BP will suddenly crash from 170, 100 to 80 by 50. they will go for what is called an alpine anesthesia, and patient may go in for renal shutdown and all those problems. But it doesn't happen like that because the patient BP comes down from 170, 100 to at most 140, 80 like that. So the contraindication was removed and now it is accepted. Subarachnoid anesthesia without an epidural in situ or final, you can do a combined final epidural also. Now coming to epidural, advantages are it helps to control the BP, improves placental blood flow, abolishes labor pain, can be extended to provide operative anesthesia also if you are giving it as a labor relief. Disadvantage, not suitable in patients with low platelets or bleeding tendency, more chances for hematoma formation, technically challenging in edematous and obese patients. General anesthesia, the indications, and the main indication is when regional is contraindicated because of coagulation abnormality. And if the patient has an obtunded level of consciousness after a fit, then it is preferable to go for, or patient has recurrent seizures, then it is suitable to go for VA. And if the patient already has one episode of pulmonary edema with hypoxia, then again the choice is general anesthesia. The patient refusal for regional and pressure response to laryngoscopy can lead to dangerously high surging blood pressure that may lead to intracranial hemorrhage. So that is the risk that can happen. So just to attenuate the response, again you can depend on magnesium, labetalol, and parenteral opioids like fentanyl, and the short-acting esmolol also can be used. And antacid anti-emetic pre-medication and antihypertensive, anticonvulsive drugs to be continued. And you can give 0.3 molar citrate solution as to increase the alkalinity of the stomach content. Intubation may be more difficult in preeclampsia if they have edema, and decreased pulmonary compliance may be there. She has received magnesium sulfate. After relaxation must be carefully monitored because all the non-deportable muscle relaxants will have a potentiated activity. The routine use of ergometrin or symptometrin should be avoided due to their hypertensive properties. So this is one of the important post-delivery precautions. And NSAID drugs should be carefully used or avoided because of the renal effect and platelet function effect. And paracetamol may be need to be withheld if there is a liver dysfunction. So all the drugs that we use in multimodal analgesia or opioid sparing analgesia, here we have to be quite cautious in preeclamptic patients. The allied topics we have to learn are physiological changes during pregnancy. It's a very common question. You can expect with any pregnant case given to you in the exam. Anemia complicating pregnancy. Anesthetic management of an elective or emergency LSCS. That also can be asked if provided if you have not done any LSCS cases. Obstetric patient for non-obstetric surgery. This is another topic that can be introduced. Management of antepartum and postpartum hemorrhage. That is another side track that they can take. And they can take ask you all about labor analgesia. Apart from the epidural, what are all the other methods of providing labor analgesia? What are all the recent advances in labor analgesia? Also, they will be asking you. They may suddenly switch over to neonatal resuscitation also, because the fetal distress, if you say, is an indication for delivery, then they can direct all the questions on neonatal resuscitation and the guidelines, recent guidelines. The uteroplacental circulation physiology will be the thing that they can ask you. So these are the things that you have to keep in mind. You want to discuss based on preeclampsia, right?
Yes.
Doubts or any questions on that? No questions at all. Very clear all the time. Right. Then shall we go to the next topic? Who is presenting the next one?
So myself, sir.
Hmm.
My case is 1.3 months old male born out of consanguineous marriage, posted for left side upper lip repair.
Hmm.
I would like to ask the informant mother about the presenting complaints of child, which will be usually difficulty in feeding since birth, any impaired suckling or swallowing, any history of frequent episodes of URI, history of nasal regurgitation while feeding, recurrent any infections. Birth history, if it is full term or preterm, normal vaginal delivery or LSCS, birth weight, if a mother had any history of drug intake or infections during pregnancy, any associated congenital anomaly or any history of ICU admissions, marital history, consanguineous marriage or non-consanguineous marriage, family history, anyone has else suffered from the same issues. Then feeding history, ask whether the child was on breast milk since birth, any history of difficulty in sucking or nasal regurgitation of milk, current feeding status, how they are feeding, then immunization history, child, whether child is immunized for age, any and developmental history. Then general physical examination includes head to toe examination, whether child is playful or like febrile, afebrile, weight, head circumference, and IV cannulation site, any pallor, cyanosis, edema, then vitals. Airway examination, look for any facial malalignment, note down the size of cleft lip and palate. Then other system examinations. Investigations, complete blood count, in case of any cardiac anomaly, echo, coagulation profile, and any urine routine. Concerns. Prior preparation, sir.
Have you ever seen a case of cleft lip being operated?
No,
Have you
sir.
given anesthesia?
No,
not
sir.
All of you in the audience who have all not seen or who have seen rather.
Sir, I have seen and I have intubated with RA tube, sir.
Okay, very good. What about Hiranmayi? Are you there, Hiranmayi?
Yes, sir.
Have you done a case of cleft lip?
No, sir.
No. Okay. Bindu, have you at least seen a case of cleft lip in your UG days, the pediatric ward?
Yes, sir. UG, sir.
Yes, sir.
You have seen. Okay. Right. Please, you have an idea how a cleft lip baby will look like. Nowadays, you get lot of advertisements. Even if you watch TV, you can have the cleft lip babies being shown in the TV for Smile Train and other NGOs who want to perform the surgery on them. So, this you get an idea about doing this. So, this is usually kept as a short case. Why
Okay,
this is there's a difficulty in managing the airway in this patient?
Actually, the airway will be hyperactive in case of any upper respiratory tract infection. We should postpone for 2 to 3 weeks.
No,
During
no, I'm asking you the securing the airway by endotracheal intubation. Why it is considered difficult in children with cleft lip or palate?
laryngoscopy will be difficult, sir.
What will happen exactly in laryngoscopy?
It will stuck into the.
Stuck inside the cleft, so we should
If you use
gauze.
your regular Macintosh laryngoscope, then the flange of the blade, the examiners will ask you which part of the blade of the laryngoscope will be giving you the problem. So the flange of the laryngoscope blade in Macintosh blade will be likely to go enter into the cleft, especially if it is a left-sided cleft. When you use a Macintosh blade, you always align it with the right border of the tongue and try to push the whole tongue on the lateral side, isn't it? So at the time we were in order to see the flange may get enter into the cleft and uh, reduce the distance of mouth opening. So introduction of the tube will be difficult. So the common question they ask you is, how do you overcome this problem? If it is a large left side cleft lip and palate, which is called the complete cleft. How do
Paraglossal
you
technique.
paraglottic
Paraglossal. Like
paraglossal
straight
technique
blade in the
of
right corner of the mouth.
right corner of the mouth. But to prevent this plant getting into the cleft, what do you do?
The saline soaked gauze or roll can be kept inside the cleft.
Gas piece can be rolled and kept and fill up that gap, or usually what uh, help that mother can be done to feed the baby without getting nasal regurgitation or aspiration.
They feed.
All-day feeding is one, but any gadget that you can fix inside the mouth of the child, it is called operator. Yes, you can keep a plastic molded support which will
Yes, sir.
occlude that gap. It is called operator or NAMS preformed palatal support. Okay?
Okay,
that can be kept in place when you intubate to prevent the this is mainly for a discussion on pediatric difficult airway. The cleft lip and palate cases, which they give you the exam, they discuss mainly about the pediatric difficult airway. So, preoperatively, you have to look for other associated congenital anomalies. What are all the other associated congenital anomalies you may have?
Peary-Robin syndrome.
Peary-Robin is associated with the cleft lip and
ESD,
palate
sir.
and the
Cardiac,
malformation.
ESD and ASD.
Cardiac, you can have VSD more commonly,
Than
rarely
ASD.
ASD also. Then, what
And
are the
sixth
other?
finger.
Club feet.
You can have skeletal abnormalities like vacral abnormality, Hepburn syndrome, where syndactyly may be there. Okay? And you may have pressure colon syndrome,
Clipple
have
fail.
Renal agenesis, sir.
Clipple syndrome. Okay? All these syndromes may be associated with cleft palate also. Okay? So look for other presence of other associated congenital anomalies. And then what is Kilner's rule of 10?
In case of weight should be less than more than 10 pounds, that 4.5 kg, HB more than 10 grams per deciliter, WBC count less than 10,000, and weeks like age less than 10 weeks in case of cleft lip, more than 10 months in case of cleft palate, and 10 kg.
So this is the rule that is given to get a good outcome. Because children may be sometimes very malnourished because of the difficulty in feeding. They may not have adequate weight gain and milestones may not happen properly. So this is one of the common questions that they may ask you about. So what special endotracheal tube you want to use?
Oral red tube, sir. So
Oral rate tube. So what is the expansion of rate tube?
ring Ade Elvin. Ring Ade Elvin.
Who are they? Somebody, you said you are intubated with rate tube. Ring Adair Elvin. Who are those people? Which country they belong to? Are they a single person or three people? What is the name of the tube that was used before the introduction of the rate tube?
Red rubber tube.
Rubber tube, what is the name for that? Rubber tube was the universal material out of which tubes were made in the olden age. Oxford tube. Earlier, it was what was used was called Oxford tube. Oxford is a university in UK. Okay? Just like your Annamala University, Bardiyar University, Bardiyar University, Oxford and Sheffield. Nuffield are the two major universities in UK which had a lot of connection with medical and medical equipment. So the Oxford tube was designed in Oxford University for use in cleft lip and cleft palate surgery in the earlier days. Have you seen that Oxford tube in your? Do they have that in your hospital?
No, sir.
Sir.
No. So that used to be like an L-shaped tube, red rubber tube with a shape like an L, with a proximal end and a tracheal distal end, which will have a bevel, and the tracheal end will be softer and the proximal end will be thicker. You have to use a metal connector to connect it to the breathing circuit. Okay?
Sir.
So that is how the circuit is used. And this 3 months old baby, what are all the challenges that you have in this surgery? When you want to ask to give anesthesia for a repair of the left-sided cleft lip,
Yes,
this
sir.
3 months old baby, what are all your challenges? What are all the things that you will have to think of before you start the case?
Difficult airway, hypothermia,
Hmm.
that is a pediatric infant, NPO guidelines,
Hmm.
like hypovolemia, hypothermia,
Hmm.
hypotension, we should watch.
Hmm.
Associated congenital anomalies and cardiac any association.
Very good. Hmm.
Mm.
Intraoperatively, preoperatively,
IV
the
access,
induction, what type of induction would you prefer in this case?
inhalational or intravenous.
Intravenous
If,
induction. When will you decide on inhalational induction for a child?
IV access is
IV access is difficult. Without IV access, will you do inhalation induction?
yes, sir. For if any difficult IV access, we use inhalation induction. Then we attend the IV access. Then we'll give like a induction agent, or we can induce with CVODs also.
Yeah. Supposing without IV access, you are trying to induce and baby goes into laryngospasm, what will you do?
100% O2 with CPAP. We try to ventilate. If we can't, then propofol 0.8 mg per kg.
You don't have an IV access. How will you give propofol? Intramuscular?
No, sir.
Ketamine can give me.
Vitamin.
Larson's
Hmm.
Larson's manual.
Hmm. What is Larson's maneuver? How does it help?
It breaks. Try to open the vocal cord.
Like to open the
Chin
vocal
lift,
cord.
jaw thrust.
What exactly you do in Larson's maneuver?
Tilt, chin lift, and jaw thrust.
It's a routine that is done for upper airway obstruction with the tongue falling back. But here the laryngospasm, as you said, the vocal cord is going into adduction. That be relieved by neck extension and jaw thrust.
No, sir.
Hmm.
If
So read
can't,
about
we can give
Larson's maneuver
succinyl
and
choline in a later
Yes, sir.
stage. We can give an intubate.
succinyl choline intramuscular again. Because the question is, we must remember the point that without IV access, if the patient goes into laryngospasm, how do you manage? That is a question commonly asked in the exam.
Yes, sir.
So there, your answer Larson's maneuver is right. But how to do that Larson's maneuver and
That
how does it
notch.
help in relieving the laryngospasm? Is the answer that has to be given correctly in the examination. And saxamitonium, as well, even if you don't have an IV access, you can give double the dose intramuscular, which will take effect as quickly as intravenous and relieve the spasm.
Okay, sir.
But all these things are done by a experienced person and not by novices, because that will be landing you in more trouble with an acute patient than a spontaneous bleed. So, for a 3 months old baby, what are the preparations you will do in the OT?
OT machine should be checked. Suction and machine should be checked. OT temperatures around 22 to 23 degrees Celsius. Difficult airway card should be kept ready. IV drugs and the fluids should be kept ready, diluted, and it should be kept ready. Then
What about the IV fluid set, infusion set?
burette set.
Burette set. Why we want a burette set?
For accurate amount of fluid, we can.
You can easily overload the children if you have a normal IV set. Okay? And the normal 500 ml bottle, if you connect, you can easily overload and produce the pulmonary edema. Okay? So it is better to calculate the required amount of fluid using a burette set and fill up that burette and correctly give the exact dose so that you don't overload the child. So, what are all the stages of surgery during which airway problem or airway obstruction can happen?
During
Left lip and palate surgery, not just the lip alone. Supposing left and palate surgery are being done together, what are all the stages during which airway can be compromised or obstructed operatively?
during positioning and during mouth gag placement.
Placement in palate. But usually lip surgery, because it is superficial, once you fix the tube, normally migration or extubation do not happen because the position of the head is not altered very much. But in palate surgery, just like your tonsillectomy, they try to open the mouth maximum and try to operate on that. So there is a chance that tube can migrate down, or it can get extubated, or it can get occluded by the blade, tongue blade that is applied, it can get inked and occluded. These are all the challenges that you have to remember. So I just show you because most of you have not done these cases, which I don't blame because it is a specialty thing. I'll just share the slide with you for that. Is it feasible?
Yes, sir.
Yes, sir.
Okay. Points to remember when answering this case scenario is you should be able to identify the type of defect. They may ask you whether it is unilateral or bilateral, complete or incomplete. You should know the embryology and development of the defects leading to cleft formation. So this is one of the common questions that you ask you: at what gestational age the lips are formed and the palate is formed? What are all the components or tissues that make up the lip and palate? And complaints by informer regarding appearance, feeding difficulty, recurrent infections in chest and ear, speech abnormality if the child is brought at a later age according to the time of presentation. And examine the child for appropriate growth for age, nutrition, development of milestones, presence of infection in the chest or ear, and look for associated congenital abnormalities or syndromes. This is very, very important because most of these things are congenital. Lip and palate defects are congenital abnormalities. So don't forget to mention about the presence or absence of other associated congenital abnormalities. And assess the anticipated difficult airway, like conditions which can produce difficulty are wide left side cleft of the lip and palate, complete bilateral cleft lip with a protuberant premaxilla, syndromic children like Trier, Robin, Rachel Pauline, and people feel, etc. And the minimal investigations needed are hemoglobin, CXR if there is a recurrent ENT opinion if there is a otitis media, dental opinion for feeding difficulty correction, like putting the operator or uploading that palatal defect. Cardiology opinion is congenital anomaly like VSD is present, and if it is causing any symptoms. Normally, the small VSD, we ignore and take up the child. We don't give too much credence to that. But if the VSD is large and it is producing excessive pulmonary flow and causing problems because of that, then we have to take an opinion from it. And plan for surgical correction, whether it is lip repair or a palatal repair or a combined lip and palate in an older child, that has to be taken care of. And this is the Kilner's rule of 10, where the age of the child should be minimum 10 weeks, hemoglobin 10 grams, weight 10 pounds, not kg, and WBC less than 10,000 to indicate there is no respiratory other infection. Then plan type of induction, whether inhalation versus intravenous, depending upon the airway assessment and your ability to secure an IV line. Because some children with cleft lip and palate, in my long experience, I have seen, are very chubby, and you don't get an dorsum of the hand, you will not be able to see very faint trace of the vein at all. So, do you have any idea how to secure a IV line if there is no vein seen on the dorsum or the elbow in a very chubby child? Which location you can usually see a good vein to cannulate?
Feet, sir.
Feet also will be chubby in chubby children. It will be just like the
Forearm, sir.
dorsum. Huh?
Forearm, sir.
Which part of forearm?
Palmar side.
Close to the
Just
wrist.
above the wrist.
See, on the wrist, the molar aspect of the forearm, the distal forearm, very, very close to the palm. If you see that, you will see a good vein in the wrist, near the wrist creases, even in chubby children. Okay? So I used to cannulate those veins only in those children because the majority of them will not look for a vein there. And calculate all drug dose in advance, dilute according to the body weight, and calculate the fluid requirement. All these things should be done before the baby is brought into the room. And be prepared for all that. Intra-op monitoring include always a precordial stethoscope. It's a very, very important gadget. Very simple, but at the same very useful. So what are the things that you can monitor with a precordial stethoscope?
Sounds
This is a
and breath
common
sounds.
question they can ask you. Where will you place the precordial stethoscope?
Near left
Have you ever
nipple.
done that?
Sir,
Where will you place it?
Left nipple, sir.
Left nipple or below the nipple, or you can keep it near the manubrium sterni also. Okay, so that will give you the air entry as well as what is the other advantage of a precordial stethoscope? What other things you can
any
detect apart?
endobronchial, if it is any endobronchial intubation, we can.
Yeah, main idea is to see whether the left side air entry is good, because the tube can migrate into right side. Any other advantage of having the precordial stethoscope?
Heart
Monitoring
sounds.
the
Heart sounds.
heart sounds. What do you find out from heart sounds?
In case of bradycardia, if no,
Bradycardia you can find out from pulse oximetry. The sound that you hear, the heartbeat sound, it will get muffled if the baby goes into hypovolemia, hypotension. Okay, so that is a very, very important clue that you can get from the monitoring the heart sound of the baby. So in pediatric patients, the heartbeat, which is loud and vibrant, there is adequate volume, will become very soft and muffled if there is a hypovolemia which we have not noticed properly. Okay? And then the multimodal analgesia with appropriate LA block. What are the LA blocks that you can think of for a cleft lip surgery?
infraorbital nerve block.
Intraorbital nerve block. Unilateral or bilateral?
In case of bilateral, sir.
Yes. So the other side also will have to be pulled and sutured. So it has to be bilateral, not unilateral.
Yes, sir.
So Challenges in cleft lip surgery, mostly pediatric patients, infants below 1 year, and may have anticipated difficulty, especially if they are syndromic. Problems of sharing the airway with surgeon during palate surgery. And if they are older than 5 months or 6 months, separation anxiety from the parents or attenders. NPO guidelines, too long periods of starvation can make the child uncomfortable as well as hemodynamic stability may be affected. And the anesthetic technique to be planned in advance on airway challenges. Pharmacokinetics and dynamics of drug used in infants to be learned well because you can, they don't have all the enzymes available for detoxifying or managing the drugs. And watch for three hypos: hypotension, hypothermia, hypoglycemia. And the instruments desaturate faster because of low FRC and develop bradycardia as a response from the cardiac side instead of tachycardia. And positioning them for surgery may result in loss of airway, so vigilance is needed. Post-op respiratory complications like obstruction, laryngospasm, aspiration to be anticipated. And the reason for post-op restlessness may be due to various reasons. It can be due to pain, it can be due to hunger, it can be due to airway compromise, or it can be separation from the mother. Okay, these four reasons you have to remember. Essential to identify and manage instead of blindly sedating the child. You should think of the correct reason and treat it. Now, this is a rapid fire method of remembering pre-op evaluation, age appropriate for birth history, associated defects, prior anesthetic history, especially when they have repeated anesthesia. Children with lip and palate defects, they come for surgery up to their adulthood. First, they will get their lip repaired, then they will come for palate repair, then they will come for speech correction with the pharyngoplasty, then they may come for palatal bone correction with bone grafting, then they may come for nose correction, especially girls, because the area of the nose will be somewhat crooked. So like that, they may come for repeated surgery. So prior anesthetic history, URI, appropriate fasting period, any treatment whether to give or not. So if you anticipate very severe difficulty in managing the airway, no treatment is advocated. And for palate surgery, usually some hospitals do routinely reserve blood because there may be more bleeding compared to because the child is cannot tolerate blood loss, so they use blood availability post-op ICU admission. Now, anesthetic management, you have to keep the equipment away from the surgical field. So it will usually go to the foot end of the patient. With the anesthesia machine, the circuit, everything will be going towards the foot end of the patient because it's a head and neck procedure. And you have to use the correct ray tube for proper fitting and unobstructed ventilation. The pediatric circuit that you use should be long and of sufficient length. We must have the standard monitoring, including precordial stethoscope, eye lubrication and eye protection should be done. And the chances of endobronchial intubation or peak inspiratory pressure obstruction all be there. Surgeon may prefer to use epinephrine infiltration, especially in palate surgery, which may cause tachycardia if you are not hypertension, if the dose is not correctly planned and given. And fluid administration, you have to keep a watch on that and hydrate adequately. Watch out for the blood loss, especially with palatal surgery. Intraoperative problems are thinking of endotracheal tube, mainstream migration of the tube tip, or accidental extubation. Sometimes the surgeon may not be able to place the tongue blade properly, so he may remove it 2 or 3 times. At the time, if the tube is not fixed properly, fixed correctly, there is a chance it may get extubated also. And intraoperative, thinking, disconnection, accidental intubation, endobronchial intubation, and spasm, all these things are the complications. Pain management can use opioids, influence field block, nerve block. After surgery, extubation, you don't do a nasal suction if palate repair is done. Or if lip repair you can do, but not much of secretion will be there in the nasal cavity. And palate repair, the surgeons won't allow you to put a oral airway if there is an obstruction. So you have to be very careful. Always take the baby to the lateral position or prone position and then try to extubate the child. And keep a watch on the pharyngeal pack. The palate surgery is being done. They will pack the throat to make sure that all the packs are removed. Sometimes peri-Robin, they may put a tongue traction sutures. And better, I always prefer to sedate the child in a very well awake position rather than asleep position, because we cannot guarantee a good monitoring the post-op ward with our sisters. So I always prefer a wide awake child. It will be, even if they cry a little bit, I don't mind, because they will be active with all the reflexes intact. And the good pain relief can do it with rectal suppositories and other things which are all available. Some surgeons have the habit of putting arm restraints for the child so that they don't put the hand or finger inside the mouth, especially after palate surgery. The custom is now slowly going off. Earlier, this was a routine thing. All plastic units, they used to restrain the arm with a plaster or a board, and a need for quite intense post-op monitoring is required. And post-op complication, there may be post-extubation proof or airway obstruction, swelling of the uvula and sublingual edema after oral surgery, and forgotten pharyngeal packs, need for re-intubation. Supposing there is a lot of bleeding palate after it may need a re-exploration, you may have to re-intubate. And this has to be managed or answers to be given similar to post-tonsillectomy bleeding. Post-palatal bleeding is very similar to post-tonsillectomy bleeding, but most of the blood will be coming out here, unlike the tonsil where the child would have swallowed many amount of blood. So these are all the types for the not seen. This is called the micro form of cleft lip, very, very small defect. This is subtotal or incomplete defect. There is only a defect in the lip. You can see underneath the palate is intact. The maxillary bone is intact. The alveolus is intact. This is a complete cleft where the alveolus is also not in continuity. So the alveolar bone is also, there is a cleft there, and it goes into the nostril sill, and you can see the ala going away. Whereas here you can see the ala is attached to the base of the nose. Even though it is little crooked, it is not separate. Whereas here the alar segment is separate. So this is incomplete, this is complete, this is complete with the defect in the alveolus also, lip and palate. And so this is bilateral. You can see the cleft on both sides here. This is the condition where I told you the bilateral cleft lip with a protuberant maxilla. So this is a complete cleft lip and palate. These are all the palatal inside. You can see the various defects. This is a small incomplete palatal defect with only in the soft palate. This is a complete one with both soft and hard palate. This is lip and palate into is the most difficult type of cleft that you can come across in your life. This is the bilateral cleft with a prominent premaxilla. So these are all the conditions, just for the sake for you to remember. So definition is cleft lip is a birth defect that results in a unilateral or bilateral opening in the upper lip, and it's a birth defect characterized by opening in the roof of the mouth caused by lack of tissue development. The definition of upper lip and palate. So this is the embryology. There are median and lateral nasal processes form at margins of nasal placodes. So the medial process, the axillary process. So you can see these are all the colored ones which are there. Sometimes if they ask you about the anatomy of the lip, this central depression is called the philtrum. This is the cupid's bow, and this is called the vermilion or white roll border, where the mucous membrane joins the skin. So these are the parts of the upper lip, and you have the defects in these things. This is the normal anatomy, normal airway, the blood supply. Development of lip and palate begins around 4th week of embryological development and completed by the first trimester, 12th week. At the end of 4th week, 5 facial prominences have been formed: frontonasal process, paired maxillary processes, that is 2 processes on either side, and paired mandibular process. So all these 5 processes are groups of tissues. They go to form the upper lip, nose, and the mandible. So this is how the whole thing is there, and this is the way it occurs. Development. Etiology, it can be genetic. Classification, of course, palate, there are a lot of classifications. It is more of surgical things. And these are the syndromes associated. Just for the OSCE sake, I thought I will include these pictures here. This is the Down syndrome. You can see the hypertelorism. There is a widening of the medial capital area between the 2 eyes. And what is the main important vertebral anomaly these children may have?
Atlanta
Down syndrome.
occipital subluxation.
Atlanta occipital dislocation. Very good. This is the, can you identify this condition?
Van der Waals syndrome.
Van der Waals syndrome. Correct. Very good. What is this? Fletcher Collins syndrome. You can see the low placed ear, okay, and the wide eyes and all that. This is the, it's a very commonly seen syndrome.
Peary Robin.
Peary Robin. Good. This is
Klippel fail.
Klippel fail syndrome. So all the names are here given here. This is name not given in this list. This is the Apert syndrome. Okay? Frontal bossing, mid-face retrusion, indactly in this hand, and these children usually have a isolated cleft palate without a lip defect. Okay? So this is called the Apert syndrome. So this is the, and the birth weight and calculation of the birth weight. This is one of the things which they may ask you in pediatric patients. How do you say whether the weight of the baby is correct for the age? To calculate that with what is called the commonest is Leach's formula. So for 3 to 12 months, age in months plus 9/2 is the formula to calculate. For 1 to 6 years, twice the age plus 8. 7 to 12 years, 7 into age in years minus 5/2. So this is the simple formula. Or you can use your hand for the age and weight. So 1 year, 3 minimum 10 kg. If the birth weight is 3.3, 3.5, thrice the birth weight should be the weight in first year. For 3 years, it should be 15. For 5 years, that is every 2 years doubling, it should be 5 times. I mean 5 kg increase, 10, 15, 20, 25, 30. Okay? Like that you can remember the weight. And this is the operator, which I told you about how to use that for occluding the cleft. So these are all things made, custom made for the defect that is done. Here you can see they have put it and fixed it so that this can be. And these are all the feeding bottles that are used for feeding the child. These are pre-surgical conditions which are used to reduce the cleft. This is called the Logan's bow. The intraorbital nerve block, you can do this so that the gap between the lip comes down. And so this is the lip repair before and after. We cleft or mucosal cleft. Sometimes you may not see any opening at all, but you can see a faint blue line here. So if you elevate the flap, you will see a cleft inside. So that is called the cleft submucous. This is the bifid uvula. Uvula is in 2 feet. This is the bilateral incomplete left-sided cleft, and both sides are there, but nose is normal. You can always see the nasal thing is there, and it has been corrected in a single sitting. This is the cleft of the palate, which has been prepared correctly by the complete cleft. So patient position for palate repair, this is just like your tonsillectomy with an extended neck. And then you put the mouth gag and open the thing, and your tube is here. So the blade will accommodate the tube in the middle with a groove and a hole there. So the tongue blade, this is how the whole thing will look like. Mouth gag for palate repair. Epinephrine infiltration with Miot sometimes for elevating the flap as well as hemostasis. And this is how the external way of giving the orbital nerve block for a child. This is the intraoral method. So this is extraoral and intraoral approach for a block. These are all the equipments that you have to remember. This is the Jackson-Twist modification for ventilation. These are all the various transparent scented masks. These are the various laryngoscope Macintosh blades, the single-handed burp application. So sometimes experienced pediatric anesthetists, they don't ask for help from outside. They can manage the burp application with their little finger after introducing the blade. This is the ray tube, household ray tube. During Adair Elvin are 3 anesthesiologists from Australia. So they designed that. This is the Oxford tube, which was used when our PG days were there. We used to use this only. So these are the various sizes of red rubber tube. You can see this portion is the endotracheal portion. It goes into the trachea. We just jetting out at the incisor level. Whereas here you have a comfortable length with the adapter. So here it used to be a point of disconnection with the metal frame. So this is the metal C connector which we used to introduce here, and then this will go to the circuit here. With the there will be what is called a catheter mount which will be connected here. And this is the Kuhn reservoir bag with the opening in the center, which you have seen. Intravenous infusion, usually you need a blue or a yellow 24 gauge you have implant, and they don't have a side port for injection. So you may require always a extension line for them, 3-way adapter. This is the burette set which we commonly use, and this is how you restrain the IV, especially in chubby children. If you can't get another access, always preserve the access and IV access securely with a restrainer. So wrist stabilizer splint. This is the peri-Robin syndrome. This is the various clefts that okay. So I think that will give you, those who have not had a chance to anesthetize cleft lip and palate, the visual impression of seeing some of the clefts and the management of those cases will give you an idea how to do that, even if you are taken by surprise. Okay?
Yes, sir.
So I think shall we stop here and take the next topic for the next class, or shall we finish it off? Who is going to present? Soundarya.
Yes,
Class?
sir.
Okay, right. Go ahead then. Finish it.
Yes, sir. Good evening, sir. My case is a 65-year-old patient, diabetes mellitus, for 20 years, posted for a wound debridement in left dorsum of the foot. First, I would like to ask the details of diabetes mellitus, sir. when it was first diagnosed, and how long patient is taking medications, and if he is taking regular or irregular, any medical treatment like OHC, oral hypoglycemic drugs he is taking, or insulin he is taking, any signs of then coming to signs, we have to rule out any sepsis, like any fever, any signs of autonomic neuropathy, any orthostatic hypotension, any resting tachycardia, any bowel and bladder alteration, and any Kussmaul's respiration, any altered consciousness, we have to rule out, sir. Then patient is for diabetes mellitus for 20 years. Any hyperglycemic emergencies like the DKA symptoms, any hyperglycemia, dehydration, high anion gap metabolic acidosis, and ketonuria, we have to see, sir. Coming to investigations, complete blood count to rule out any anemia, and WBC count to rule out infection, and arterial blood gas or venous blood gas to rule out anion gap and metabolic acidosis. RF renal function test and serum electrolytes, specifically serum sodium and serum potassium, urine ketones and plasma ketones, blood glucose for measured every hourly, and ECG, chest X-ray, and echo, sir. In management, rapid a patient is dehydration, so we have to administer rehydration with the fluid therapy, sir. Initial fluid therapy is 0.9% normal saline in first hour, 15 to 20 ml per kg per hour, approximately 1 to 1.5 liters, and maintenance with 4 to 14 ml per kg per hour to adequate to maintain the blood pressure and urine output and mental status. Then after correction of fluids, we have to start the insulin therapy. Should be only route, not subcutaneous route. Once hypokalemia excluded, IV insulin started 50 inter-units of actrapid in 50 ml of NS at 0.1 inter-units per kg per hour. It should be corrected not rapidly, 50 to 70 milligram per deciliter per hour we should correct. And rapid correction should avoid to hypoglycemia. And potassium replacement, if insulin fluids and hyperglycemia should give at 20 to 40 milliequivalents per liter per hour, and the serum sodium and serum potassium will check 2 to 4 hours. And ECG also we have to monitor with any ECG changes, hypokalemia changes. Sodium bicarbonate usually we should not administer. If severe acidosis with profound acidosis like pH less than 6.9, we have to consider the sodium bicarbonate. And antibiotics should give and a DVT prophylaxis. And patient is diabetes, increase the risk of aspiration, we should give anti-aspiration prophylaxis and the NG tube placement, and urinary catheterization, and continuous ECG monitoring. And coming to anesthesia, we have my technique for a patient is posted for wound debridement in left dorsum of the foot. I'd like to go for a regional anesthesia, sir, in single short spinal or nerve blocks, sir. And regional is advantages over than general anesthesia. Advantages are patient is awake, so we can easily monitor any patient hypoglycemia, and easily and avoid better if difficult airway. General, yes, sir. We can avoid general, sir.
But in case patient refuses regional, what will you do? You cannot force your technique to the patient, isn't it? Because the patient is saying, I don't want, last time I had a hernia surgery, then that is poking me so much in the back, I developed backache. So I don't want any injection in my back. That is the refusal by the patient. What will you do?
Then I'll go for general anesthesia with LMA placement, sir.
LMA. Supposing, what are the contraindications for using LMA in a diabetic patient?
If in risk of aspiration diabetic gastroparesis.
So autonomic neuropathy, the
Neuropathy.
patient has got EGERD features or the features of low motility, then you have to be very, very careful. So which type of LMA will you prefer in that situation?
Second generation LMAs.
Like, example,
HL or
Pros?
pros LMAs.
protector LMA. Have you heard of protector LMA?
No, sir. I didn't use, sir.
You have not heard about it. So there is a Procil LMA is the first second generation LMA with a gastric aspiration tube.
2%.
Then there are other multiple Basta mask is there. You can have eye gel with a gastric tube. All these things are there to use instead of using the regular classic LMA.
Yes, sir.
But what are all the challenges that you may face with GA in a diabetic patient?
Hypoglycemia masks, sir.
You cannot detect hypoglycemia intraoperatively. Very good. Then, starting from supposing airway management, what are
It
all
is
the
difficult.
clinical?
Stiff
When
joint.
will you know? Once again, when will you can clinically assess that the airway intubation may be difficult, challenging in a diabetic patient? What changes in the patient's musculoskeletal system will tell you that there may be difficulty in intubation?
Joint instability, sir. Mainly atlato-occipital joint.
Joint instability or restricted movement of
Restricted
the
movement.
cervical spine?
Restricted movement of
Glycogenation will
cervical
cause
spine.
restricted movements.
Extension of the head, okay, cervical spine, that may be there. In that case, what sign will be elicited?
Palm print sign and
Prayer sign.
prayer sign.
Prayer sign is more easy. Just all of when you keep the hands together, if you see a gap like this, that means the prayer sign is positive.
Yes.
But if you are able to oppose both the fingers, both the hand fingers together without a gap, that is the normal way you can do that. But if you keep it like this, if the diabetic patient is keeping only like this, that means it's a positive prayer sign where he is not able to oppose the fingers of the hand. That patient will have difficulty in mouth opening as well as intubation. Okay? So what are all the nerve blocks you can think of this procedure? You said you will go
Popliteal
for a dorsum of the foot. If you want to do a debridement, which nerve you have to block?
So popliteal sciatic nerve block, sir.
Popliteal-sciatic nerve. Is there a nerve like that? Is popliteal nerve or sciatic nerve?
Sciatic nerve, sir.
Sciatic nerve. Okay. What is the nerve supply between the great toe and the second toe? What nerve supply?
L5S1, sir.
Hmm.
Nerve,
Kind of
deep renal nerve.
what is ankle block? When is ankle block indicated?
Ankle block consists of 5 nerves blocks. Sir. It consists of 5 blocks, nerve blocks.
5 nerves are to be blocked, correct. But what are all the 5 nerves? When is it?
Superficial perennial, deep perennial nerve, sural nerve, and tibial nerve.
Saphenous nerve, sir.
Saphenous nerve. So all these 5 nerves have to be blocked. But what is the contraindication for ankle block?
Infection at the site of infection.
So any dry gangrene with no edema or local infection at the site of injection, you can definitely give ankle block. Have you ever seen or given an ankle block?
Yes, sir. 5 years before.
Okay. Right. So we'll just see the slides. We are running out of time. So this is the case scenario that has been given. This is the picture of a classic case of infection that is being seen here. So this is the case summary that is being given here. Now patient is drowsy, tachypneic and tachycardic. The patient has moderate pain in the ulcer site. Patient is dehydrated and febrile. So history, patient has a diabetes mellitus for 15 years. So diagnosed during a master health checkup. Why this is, how it was diagnosed, history is important. So you want to ask how you came to know that you are a diabetic.
Time.
See, earlier those olden textbooks, they used to say diabetic patients have
MI.
excess thirst, excess hunger, and excess urination, polyuria, polydipsia, polyphagia. That was
Yes,
the
sir.
classical description of a diabetic patient in the olden days. They used to feel very hungry often, so they used to eat lot, polyphagia. They used to feel very thirsty, so they keep on drinking lot of water, so that is called polydipsia. And they used to urinate a lot, so polyphagia, polydipsia, polyuria. So these are the three polys that they were used to describe diabetic patients. But nowadays it is very rare to see patients like that. The scenario has totally changed. Even younger patients are being diagnosed with diabetes because of the stress in their work, especially IT people at the age of 25, 30, they are all becoming diabetic people. And so the classical polyuria, polydipsia, polyphagia is not anymore described in any textbooks. So they quietly become diabetic and suffer for a long time until some target organ dysfunction sets in. Like suddenly you get a edema one day and then you go and get up, you have a urinary protein positive, then you do an ultrasound, you have a medical renal disease, then you check your blood sugar, it is somewhere at 300, 350. You do HbA1c, it is about 8.9, 10 like that. So uncontrolled, undetected diabetes is becoming very common nowadays. So that is the reason why you must always ask how the diabetes was detected. Nowadays people are quite conscious and they go for regular periodical master health checkup at least once in 2 years, and at that time they may be detected. Or when they want to take a insurance policy, sometimes a large amount or large cover for insurance, they always subject the patients to the candidates to medical examination. So that time they may be detected. Or some people may have a not chronically not healing wound or some other dissociation like erectile dysfunction in a married person. This is how it may exhibit. So it is always take upon identify why patient, how the patient was diagnosed as a diabetic, and what are all the drugs that patient has been taking on. This is another case scenario where I included these things. Patient had a good control till the development of ulcer, which he routinely used to. Nowadays, people do what is called home monitoring of glucose, HMG, by using the capillary blood glucose testing. They do it at home itself. Majority of the patients are aware of that. So you must always find out how they have been following up about the control. If they are starting on treatment, how often they check their blood sugar, whether they do it at home or whether they go to the lab and get it tested by a venous sample. So that control is very important. And random plasma glucose became 340 after the ulcer in the foot. And hence he was started on mixed insulin 20 units BD, and latest random figure is 245 and the HbA1c is 8.4. Now with the HbA1c value, can you estimate his average glucose? Do you know how to calculate the average glucose of the patient with the HbA1c value? Are you aware of the formula? Yes or no quickly, so that you can. So this is the formula that you have to use. 28.7 multiplied by the HbA1c value, you get that product. From that you subtract 46.7, then you get the average glucose value. This is the formula that you have to use. So there are two values, 28.7 and 46.7. So first you multiply the 28.7 with the HbA1c value. Out of the product that you get, you subtract 46.7, then you will get the average blood glucose. So the majority of your lab reports will tell you the average blood glucose based on this only. You can easily find out. And this gives the control or the value for the last 3 months, because the lifespan of an RBC is about 120 days, 90 days to 120 days. So till the time it will be attached to that, so you can have a rough idea about the control of the glucose. And in this case scenario, I have added these things. Patient had chest pain 4 years ago, diagnosed as stable angina, underwent coronary angiography, found to have a single vessel disease with LAD, and he was put on metoprolol, atorvastatin, Ismo, Profilet, and Ramipril. And he also had elevated renal parameters like urea 60, creatinine 1.6, and he had laser coagulation for vitreous hemorrhage 3 years back. Now, if this history is given, what is the significance of the above history? What are the target organ dysfunction in this patient?
Microvascular complications.
And microvascular complications, both are there. Okay, so because vitreous hemorrhage retinopathy is a microvascular complication, renal is a microvascular, whereas coronary is a macrovascular complication. So he has developed all the macro and microvascular complications. And patient had sincere needle sensation, both feet and both hands, the burning tight. Now he has a reduced sensation, and he has altered bowel habit with constipation or diarrhea, and he has symptoms of GERD, and he has erectile dysfunction. There's occasional giddiness when getting up from bed in the morning, but he walks 3 kilometers every morning comfortably, able to climb 2 flights of stairs without SOB. What is the inference from the above history?
Diabetic autonomic neuropathy.
Autonomic neuropathy, excellent. So patient has already got features of diabetic autonomic neuropathy. So once you suspect that patient has diabetic autonomic neuropathy, what will be your choice of anesthesia for this patient? Will it still be a regional central neuraxial block with a subarachnoid?
Should
You should avoid in patients with established diabetic autonomic neuropathy, better not to go for regional block or central. Nerve block can be given, but not central neuraxial block. Okay? Now, patient has history of weight gain, dry skin, and hair loss due to hypothyroidism, and significant difficulty in extension of neck to look up. Patient had symptoms of hypoglycemia when started on OHA initially and corrected with total glucose. No history of drowsiness, excessive urination, or thirst after developing ulcer. Patient uses footwear while going out. Has not taken any native treatment or any surgical treatment. So, what are the important deductions from this particular above history? So, every single extra information that you get. So, what are all the things that you will make out of those things? What is the importance of this hypothyroidism? That being replaced with L-proxin 50 microgram every day. What are all the complications you can have because of this hypothyroidism?
Mixed
We tolerate a very cold OP for surgery.
tolerance.
You will have cold intolerance. You may have delayed recovery. You give DA hypothyroid patients. You have a delayed DA recovery because of hypothermia. And he is already on supplementation. So should the supplementation be continued or it can be stopped?
Yes, sir.
To stop L-troxin. The patient is hypothyroid.
Sorry, sir. Okay.
You
We
have
should
to give it
continue
on
with
the
it.
day of surgery because this drug is, how is it usually taken? This L-troxin. After food or before food?
With support.
Should be given early in the morning. First thing in the morning in empty stomach with a sip of water. That is how it should be taken even for your regular usage. So the same thing can be continued on the day of surgery also. So any patient, hypothyroid patient who is on L-troxin supplementation should continue the drug the day of surgery with 6 of water in empty stomach. The usual time of 6 o'clock. Unless the surgery is going to start at 6 o'clock, you can give it 2 hours earlier than that. But it should continue. Difficulty in extension of neck indicates that there may be difficulty in laryngoscope and intubation. So this is the second thing. Symptoms of hypoglycemia when she started on OHA always poses a risk that patient can develop hypoglycemia because of prolonged fasting or the unduly not stopping some of the anti-diabetic drugs, like long-acting drugs if they are given, they can go in for hypoglycemia. But there is no excessive history of drowsiness or urination, which are all indicative of DKA. Okay? So that is not there. Patient uses footwear while going out and he has not taken any native treatment. So this is a very important thing. All chronic ailment people, they always you must ask history of any treatment other than allopathy. So that may be the drug interaction or the interference with our techniques which may cause unexpected complications. So that is the importance of the above information that is given here. Now coming to examination of the patient, what serious tests are important in this patient? Now that you know there is a features like autonomic neuropathy are there, so what are all the important serious clinical tests that you would like to perform in this patient?
Orthostatic hypotension, sir.
Examination of the blood pressure in the lying and standing posture to rule out orthostatic hypotension. Okay. So, and what are the signs to be looked for because patient has limited neck extension? Which already I told you. What is the sign you have to look for? Prayer sign. What test can be done to assess severity of hypothyroidism? Hello? Yeah. இப்போ நான் கிளாஸ்ல இருக்கேன்டா ஒரு அப்புறம் சின்ன ஹாஸ்பிட்டல் தான் கூட்டிட்டு போகணும். ம் ம் இருந்து அங்கே யாரும் இல்லையா டிபி டாக்டர் தான் இல்லைன்னா அங்கே விவேக் ஐயர் கிட்ட தான் சொல்லணும். கல்யாணம் எடுத்து விவேக் ஐயர் விவேக் ஐயர் நம்பர் இருக்கா அவங்ககிட்ட? சரி நான் கிளாஸ் முடிச்சுட்டு தான் பேச முடியும். So, severity of what test can be done to assess severity of hypothyroidism? What is the clinical test? Supposing patient has not been taking the thyroxine supplementation regularly, what is the clinical test that will show that he has been not corrected with the hypothyroid state? Any neurological examination which you do routinely?
Exaggerated patellar reflection, sir.
Patellar reflex illama.
Plantar reflex.
Ankle jerk. There will
Plantar
be
reflex.
pseudo response. There will
Pseudo-
be slow, delayed relaxation. Okay. So the ankle jerk is a very important test. That
Yes,
is
sir.
the thing that they will do in Nicodema form.
Yes, sir.
Ankle jerk delayed response to
Yes, sir.
relaxation. And local examination, how to describe the ulcer. The examination, if they keep a real patient, they will ask you to describe the ulcer. How do you normally in the surgical training lab, how are you taught to describe an ulcer?
Site of the ulcer, any granulation tissues, and according to classification.
Wagner classification is based on the
Ulcer.
other factors. Okay, so normally size, breadth and length,
Okay.
how many centimeters, location, margins, bed of the ulcer, and whether discharge or offensive smell, and whether it is painful when pressed, and the warmth. Okay, so these are all the features that we have to describe about the ulcer. And Wagner's classification. What is the importance of this Wagner's classification?
Depth of involvement, sir.
So it will decide what? Decide the treatment. Okay, Wagner's grade is important to decide how deep or how extensive the wound is, and that is going to decide whether it is going to be a simple debridement and allow it to heal by its own healing process, or whether you have to put a simple graft, or whether you have to put a rotation flap, or you have to put a microvascular tissue and then do a free flap. All these things, or you have to amputate that limb. All these decisions can be taken by doing the Wagner's grading of the wound. And monofilament shows absence of sensation of third to fifth toe, which again, what is the indication of this monofilament testing? Sensory loss. Okay, then ankle jerk is normal, which indicates motor power is normal. So there is no, normally whenever you have autonomic neuropathy, you have to check for the sensory motor deficit also. Here there is a sensory deficit, but motor conduction is normal by testing the ankle jerk. And the dorsalis pedis and posterior tibial pulsations are normal, which indicates the peripheral vessels are okay. There is no occlusion, or major vessels are not ischemic. Ankle brachial index. What is ankle brachial index? What is the importance of ankle brachial index? How do you do that ankle brachial index?
Sir, measure the BP of the lower limb and measure the BP of the upper limb. Systolic pressure of the lower limb divided by systolic pressure of the upper limb.
It should be less.
BP means you have systolic and diastolic.
Sir, lower limb we can only measure the systolic BP, sir.
Both. You have to measure the systolic blood pressure in the upper limb and systolic pressure in the lower limb and find the ratio of that. Okay, that is called the ankle brachial index. And that will indicate the degree of occlusion. That is the reason, because the brachial is very close to the heart. Normally it doesn't get occluded. So if your lower limb blood pressure, systolic blood pressure, is almost as equal as the brachial pressure, that means the distal flow is normal. Whereas if there is a block in the distal flow in the leg, like your popliteal or your femoral itself is blocked because of the diabetic vascular changes, then the ankle systolic pressure will be very low. Okay? So that is how you find out whether clinically you can see whether there will be any use, whether the patient needs any revascularization or not can be detected. And whether when you want to do a flap also, if you want to put a local rotation flap, that flap may not survive if the ankle flow is not good. So that is the importance of that ankle brachial index. It should be normally 1. Less than that is considered as solution in the distal portion. So, what is the importance of Wagner grading? What is the importance of inference of monofilament test? What is the importance of ankle jerk? What is the anti-brachial index? What is the normal value? All these things may be asked in the exam. And so this is the grading. Grade 1 is superficial ulcer. Grade 2 is ulcer extending to ligament, tendons, and other joints with no osteomyelitis. That means the bone is not involved. Then deep ulcer with abscess or osteomyelitis is grade 3. And grade 4 is gangrene forefoot. Grade 5 is extensive gangrene. So from grade 1 to 3, you can do debridement, natural healing, SSG or flap cover. That is the treatment modality that you can think of. For grade 4 and 5, it should be usually amputation because already the tissues have become gangrenous. So this picture tells you various grades of how these things are. You can see this portion is gangrenous, this forefoot is completely gangrenous, grade 5. And this is another classification which is called the University Texas classification system. Now, what are the investigations we have to do in this case? Normally, routine CBC, including all the values, glycemic control for fasting plasma glucose, postprandial, and HbA1c, EKG for any skin changes, RR interval for autonomic function, CXR for cardiac size, atypical pulmonary tuberculosis, and echo for LV function, regional wall motion abnormality, Doppler study of lower limb vessels to see the blood flow, and wound swab for culture and sensitivity for appropriate antibiotic therapy. We use the abdomen to rule out medical renal disease because we had a elevated urea and creatinine in this case. How to optimize this patient? Wound infection control with suitable antibiotic, and glycemic control by dose adjustment with short-acting insulin, and stabilization of comorbid conditions, ketone estimation, correction of DKA if present, uric acid estimation and treatment, and estimate GFR, steps to assess grade of renal function, cardiac medication and management. All these things have to be done. Advantages, disadvantages of regional anesthesia for any management of diabetic foot: less stress or less fluctuation on sugar levels, easy to identify hypoglycemia as we mentioned, and good intra and post-op analgesia we can provide by adding additives and avoiding airway manipulation and aspiration tricks. These are the advantages of regional for a diabetic foot management. Disadvantages are hypotension with SAB, especially will be severe if autonomic dysfunction is already present. Limited duration of anesthesia for the single shot final. So you must know that the surgeon can finish the surgery within the duration of the block. Otherwise, you have to go for a prolonged block with epidural catheter or something like that. So single shot is only for small procedure, short-term procedure. Epidural contraindicated if the wound infection is very severe because epidural abscess can be formed because of the translocation of the bacteria. So you have to avoid epidural for that. And the patient can develop hypothermia and shivering because of the neurovascular blockage. And GA indications are long duration surgery like a pre-flap or a microvascular flap, presence of autonomic nervous system and involvement, patient refusal for RA, and severe infection in the wound also contraindication. Advantages are patient comfort, provides good operating conditions for the surgeon. Disadvantages are difficult airway ability to detect operative hypoglycemia. In the intraoperative hypoglycemia, you cannot detect because the tachycardia, sweating, all these things which normally happen in hypoglycemia can happen due to other reasons also in the patient under GA. So that is one of the disadvantages. So, but nowadays with the availability of capillary blood glucose estimation at the bedside, we can easily detect that. So this was one of the older methods where we have to send the blood sample to the lab, wait for the result. Those days it was difficult, but nowadays it is not a big issue. And what are the possible RA techniques that you can use in these cases are, you can use single shot subarachnoid, you can use combined spinal epidural, you can use continuous epidural, nerve blocks, entry blocks for dry gangrene without infection. And rarely you can use intravenous regional anesthesia also. I have used this in a couple of occasions for below knee amputations, because we can cannulate the vein above and then use the tourniquet and use the same tourniquet for regional anesthesia also in the very sick patients. Successfully done that for amputations in patients with severe deep pain and all those cases. And instructions for elective procedure: free of starvation, anxiolysis, anti-aspiration prophylaxis, stop antiplatelets if they are already on, stop AC inhibitors as you do for all cases, check CBG before shipping the patient to OT and inform the value. With regard to diabetic medication, this is the common question they may ask you in the examination with this type of diabetic ulcer food. If the patient is taking only oral hypoglycemic agent, if the surgery is in the morning, skip all morning dose of this regular oral hypoglycemic agent because patient is starving. And check the blood sugar before shifting to OT. If CBG is less than 100, start a 5% dextrose with the normal saline at 75 ml per hour. If CBG is more than 200, just start a normal saline infusion without dextrose. And resume oral when permitted, and at that time you can give oral hypoglycemic agents after taking normal diet. The second category, well controlled with oral hypoglycemic agent, but surgery is in the afternoon. Here the surgery is in the morning, so there is overnight, midnight starvation, so there is no problem. Whereas if the patient is posted for surgery in the afternoon or evening, that happens in private practice, then what you do, allow normal breakfast. If metformin and voglibos are drugs which have a long life, a long action, give half the dose of glimepiride or the sulfonylureas that they take. If we give only half the usual dose, rest of the instructions for this one. With regard to checking their blood sugar and starting the IV infusions, it's like the same for the earlier case. The third category, patient on OHA and insulin, surgery in the morning, omit all OHA, all the oral tablets to be stopped. Check fasting sugar. If it is 100 to 200, no insulin. But if it is less than 100, start 5% dextrose infusion, 50 ml per hour. If it is more than 200 divided by 150 and obtained value, give the plain insulin instead of his regular whatever insulin he has taken. You must use only plain insulin subcutaneous to control the sugar. For the fourth category, patient on OHA and insulin, but surgery is in the evening. Again, allow normal breakfast. Avoid all the oral hypoglycemic agent, but give half the usual dose of the same Mixtard or whatever insulin he has been taking. Give half of the dose after the patient takes the breakfast. And start NPO from watch out for symptoms of hypo. Start 5% dextrose, again if the blood sugar is less than 100. Instructions for the above four groups, receiving oral intake will be allowed early in the post-op. So for all superficial surgeries like diabetic ulcer foot and other things, these are all the things that you have to follow. And patients who have cardiac, neuro or pregnant patients coming for such surgeries, they require what is called the tight control. So this is achieved by intravenous infusion of short-acting insulin, and two regimes are popular. One is the Alberti Thomas, which is called the fixed glucose infusion regime. The second is the variable insulin infusion by Watts et al. And so alternate to that is the Velour regimen, which is claims its advantage because of using only a burette set with a plain insulin without a need for any infusion pump and other gadgets which are required. So you can read about that in the available in the books. So this Cleft harvested for reconstructing a wound like this. So extensive debris are done, bone and tendons are exposed, and this flap has been harvested and this has been reconstructed here. That is just for the here. Yeah. Okay.
Yes, sir.
So, Hirunai, are you in the hospital or are you at home?
Sir, I'm at home only, sir.
Okay. I will call you. I need a help from you after the class.
Yes, sir.
You are in Sims only now?
Yes, sir. Yes, sir.
Okay, I will just call you after.
Okay, sir.
Any doubts now on this?
No, sir.
Sir.
Shall we say goodbye?
Yes,
Good
sir.
night.
Yes, sir.
Thank you, sir. Good night, sir.